Ladies and gentlemen, we'd like to get started so we stay on time as much as possible. Thank you. Good afternoon. Welcome to the National Press Club. Great facility. We're pleased to be here, and we're pleased that you're able to join us for the Emerging Science in State and Community Tobacco Control Policy and Practice. I'm Todd Rogers, Senior Scientist in the Center for Health Policy Science and Tobacco Research at RTI International and co-director of the Coordinating Center for the State and Community Tobacco Control Research Initiative. I'm hosting the meeting on behalf of the Steering Committee of the FCTC Initiative, which consists of 7 funded research groups, the Coordinating Center and the National Cancer Institute. And I'd like to acknowledge the co-chairs of the SCTC Steering Committee for their leadership in designing and developing this event, Dr. Frank Chalupka of the University of Illinois at Chicago, and Dr. Patricia Nez Henderson of the Black Hills Center for American Indian Health. This is a public capstone meeting for the State and Community Tobacco Control Research Initiative, which has been funded for nearly 5 years by the National Cancer Institute to support innovative research intended to yield rapidly actionable findings to advance state and community tobacco control policy and practice. SCTC investigators and the Coordinating Center at RTI are charged with developing effective strategies and translating and disseminating research findings for a wide array of relevant audiences. Presenters at today's event will summarize selected key findings from the initiative, illustrate how partners from the tobacco control policy and practice communities have used SCTC research to advance their work, and equally important, how SCTC research has been guided by the needs of our partners. We expect that today's presentations and panel discussion will stimulate dialogue among policymakers, federal agencies, researchers, and practitioners about the ongoing need for a robust state and community tobacco control research portfolio to complement investments in tobacco regulatory science. The event will begin with a presentation by Dr. Elizabeth Janexi of the National Cancer Institute, who will offer an overview of the SCTC research initiative. Next, 4 SCTC representatives will each briefly describe key research findings from across the initiative, including studies that are being led by other investigators from SCTC who are not in today's panel. These folks who are not on today's panel but whose research will be presented include Dr. Nez Henderson, Dr. Scott Leischow of the Mayo Clinic, Dr. Doug Luke of Washington University, Dr. Kurt Ribisel of the University of North Carolina, Chapel Hill, and Dr. Shuhong Su of the University of California, San Diego. All SCTC investigators have conducted their research in collaboration with other academic centers, federal, state, and local government agencies, and tobacco control advocacy organizations. So following the presentations by SCTC investigators, 4 recognized leaders from the tobacco control practice community will share their experiences collaborating with SCTC investigators and using SCTC research to support their efforts. They will also provide us with their wish lists of additional research needs that can advance tobacco control efforts at the state and local levels. Our distinguished guest, Dr. Howard Koh, former U.S. Assistant Secretary of Health, will offer his perspective on persisting critical needs in state and community tobacco control. Dr. Koh will then moderate a panel discussion among the 8 presenters, which will include consideration of questions posed by Dr. Koh by audience members here in the room and by the audience viewing this event that is streaming live on the internet. To maximize the time for discussion, I will introduce our presenters with minimal biographic information. I'll note that detailed speaker bios are provided in the materials distributed in the packets here in the Press Club in downloadable form on the event website. Our first group of presenters is led by Dr. Elizabeth Janexi, Program Director of in the Tobacco Control Research Branch of the National Cancer Institute. Dr. Janexi serves as the project coordinator of the SCTC Research Initiative and leads NCI's efforts to evaluate the initiative. Dr. Janexi will set the stage by providing an overview of the initiative, highlighting how state and community-focused research can address enduring issues in tobacco control. The four investigators representing the initiative on today's panel are Dr. Frank Chalupka, Dr. Lisa Henriksen, Dr. Pamela Ling, and Dr. Michelle Kegler. And briefly, bios for each of these are as follows. Dr. Chalupka is a distinguished professor at the University of Chicago, where he directs the UIC Health Policy Center. He's an internationally recognized expert in tobacco control policy, and today he'll describe SETC research to optimize the impact of tobacco pricing policies. Dr. Lisa Henriksen is a senior research scientist at the Stanford Prevention Research Center, where her research focuses on the regulation of tobacco products and tobacco product marketing. Dr. Henriksen will present an overview of the broad range of SETC research that focuses on the tobacco retail environment. Dr. Pamela Ling is a professor of medicine at the University of California, San Francisco, and co-director of the UCSF Center for Tobacco Control Research and Education. Dr. Ling, a physician scientist, conducts tobacco, media, and social marketing to youth research. She will describe SETC research on new and emerging tobacco products, how these products are being marketed to young people, and innovative approaches to counter tobacco product marketing. This portion of the program will conclude with a presentation from Dr. Michelle Kegler, Professor of Behavioral Sciences and Health Education at the Emory University Rollins School of Public Health and Director of the Emory Prevention Research Center. She's a recognized expert on community-based chronic disease prevention programs. Dr. Kegler will offer an overview of the SETC research and dissemination efforts to promote smoke-free homes and support household members to quit smoking. So let's begin by asking Dr. Janeski to join me at the podium.
Thank you very much. Good afternoon. I'm Elizabeth Janeksi, and I'm here from the Tobacco Control Research Branch, and that's located in the Division of Cancer Control and Population Sciences at the National Cancer Institute. And I'm the project scientist coordinator for the State and Community Tobacco Control Research Program, and that has been funded since 2011 by NCI. We call it SETC for short, so when you hear that, that's us. You may be aware that the 1964 Surgeon General's report on smoking and health spurred education, programmatic and policy interventions, litigation, social norm changes that basically revolutionized the way that Americans view tobacco. Cigarette smoking prevalence among U.S. adults has declined from 42.4% back in 1965 down to 16.8% in 2014. It has been estimated that tobacco control efforts since 1964 have prevented approximately 8 million deaths and extended mean lifespan in the United States between 19 and 20 years. However, tobacco use remains the leading cause of preventable premature death in the United States today, including mortality from lung and other cancers. High use persists based on income and other factors such as comorbid mental health conditions. For example, as you can see in this next slide, in 2014, the current smoking rates were at about 15.2% for those who were above the federal poverty level. However, below the federal poverty level, the rates were 26.3%. For comparison purposes, you'll see on this slide that I've placed this red line that represents the 2014 current overall prevalence rates for the United States. And so you can see the disparities in income. It's very important to point out that in addition to differences in prevalence, there are also big disparities based on secondhand smoke exposure. While secondhand smoke exposure among non-smokers dropped from 50% in 1999 to about 25% in 2011, the exposure levels are still quite high among several groups, including those who live below the poverty line and among African Americans, both adults and children. Because of these disparities in cigarette smoking and secondhand smoke exposure, we're observing troubling inequalities in cancer incidence and mortality in the United States. In addition, the 2007 National Health Interview Survey revealed stark disparities in cigarette smoking prevalence among adults with lifetime mental illness, as shown in this graph here. Once again, I've overlaid the red bar to show you where the current 2014 general population prevalence level is, so that you can see how far above these categories are. Similarly, large disparities exist when we look at certain demographic categories. For example, individuals who are of American Indian or Alaskan Native descent continue to exhibit high rates of tobacco use. Finally, we also see much higher than average prevalence rates among LGBT men and women in the United States. There's certainly a need to extend cessation services and make them more widely available to these vulnerable populations, and there are many efforts underway to do just that. However, we also know that from decades of our research that tobacco control policies are also effective tools that need to be employed to target smoking prevalence in the United States. Policy is effective because of its broad reach, its ability to change social norms, and it can be implemented at fairly low cost compared to individual interventions. For example, and you'll hear more about this later, policies that implement taxes, establish smoke-free workplaces, or restrict marketing are very effective for lowering smoking prevalence rates and for increasing support for tobacco-free environments. Historically, the states and communities have played a very important role in implementing tobacco prevention and control policies and programs. It is for this reason that in 2011, the National Cancer Institute funded the State and Community Tobacco Control Research Initiative. This initiative was really designed to support innovative research that would hopefully inform the states and communities with their tobacco control efforts. And as you can see, the goals here, each of these priority areas you'll hear about in the upcoming talks. Under the SCTC program, NCI funded 7 research sites and 1 coordinating center. And this represents over 70 investigators across the sites who are then connected to approximately 129 different affiliated tobacco control partners all around the country. This is a list of the institutions that were awarded grants under this Cooperative Agreement Research Program. And this afternoon, you're going to hear from 4 of these scientists, and they're going to tell you about some of the key findings from the research that they've been conducting under this initiative over the past 5 years. In addition to the main projects at their respective sites, the investigators also had the opportunity to conduct ancillary studies, which we called collaborative developmental or pilot projects. These were meant to be as a rapid response mechanism so that they could respond to sensitive or new areas of inquiry in tobacco control. So for example, when the initiative was funded in 2011, e-cigarettes were just coming out and they weren't very well known. However, now they're quite ubiquitous and widely used. So the pilot projects were a unique opportunity for our scientists to go in quickly with rapid response pilot projects and conduct some of the early research for public health programs. Overall, we have funded 41 of these pilot projects over the past 4 years, and they were conducted by about 64 different investigators and covered a variety of topics, as you can see here. The initiative also created some topical working groups so that we could encourage collaboration on a variety of relevant tobacco control policy areas that are cross-cutting. And some of the products and research that you're going to hear about later today were a direct result of these working groups. We're in the 5th year now, and it's the final year. It's been very productive. There are well over 100 peer-reviewed scientific publications from the initiative so far, and over 285 conference presentations so far. In addition, the sites are authoring reports, briefings, testimony for various policy stakeholders, open access websites and toolkits that are available for free download for states and communities to use, as well as press briefings like today. If you're interested in learning more about the initiative, I would encourage you to check out the website. Among other things, on the website, you'll see that we have a running list of the products that have been produced by the researchers. Well, while our research investment has been significant, further inquiry will be critical to continue progress. Because if there's one thing that can be said about tobacco control, change is the constant. For instance, as discussed earlier, tobacco use is increasingly concentrated among vulnerable populations, and light and intermittent smoking is on the rise. Finally, with our successes in workplace clean air laws, now it's really the home that is the largest source of secondhand smoke exposure. Second, we are continued to face with new products on the market, and these include both combustible and smokeless products. Consumers are basically introduced to and consuming a wider variety of products than before, more than just cigarettes. They have cigars, little cigars, cigarillos, electronic nicotine delivery systems, water pipes, and who knows what's next. In fact, now, as of March 2016, 4 states in Washington, D.C. are also allowing for recreational marijuana use, and our surveillance systems are indicating that many of these products are being combined with marijuana. They're combined with cigarettes, cigars, and certainly with the electronic nicotine delivery systems. So this increased alternative product use may wind up influencing our overall tobacco patterns and could impact policy around the country. FDA regulation is coming. However, the 2009 Family Smoking Prevention Tobacco Act did give the states some latitude now. They have lifted preemption and they are allowed to address tobacco marketing in their communities. This will allow for some new, novel policy approaches at the local level. And finally, with the ACA, Affordable Care Act, we're hoping that more individuals will be receiving funding and help for cessation services. And lastly, we continue to look around the globe to our partners who do tobacco control elsewhere, because we can always learn from other countries what works and see if we can make it work here as well. Thank you very much.
Thanks, Liz. I'm Frank Chalupka. I'm from the University of Illinois at Chicago, and I'm going to highlight some findings from a couple of our projects, looking at different issues around trying to optimize the impact of tobacco pricing policies. So we know from extensive research that tobacco tax, tobacco price increases are the most effective way that we can reduce tobacco use. We see that this is particularly true when it comes to some of the highest risk populations. When price goes up, consumption comes down. When price goes down, consumption goes up. Follows the basic laws of economics. We know that prevalence is affected by tax and price increases. When we raise tax, when we raise price, we see smokers want to quit smoking. Many of those smokers are going to be successful in doing that. And then we know that some populations, particularly kids and low-income populations, are going to be much more responsive to price, 2 to 3 times more responsive to price than overall adult smoking is. And this is factored into state policy. We've seen big increases in state taxes over the last 15 years. You can think about almost an epidemic of taxes, at least in some parts of the country, with taxes going up and up and up. But we have a lot of states that are still lagging way behind. So I'm from Illinois. I'm from Chicago. Our tax is the highest in the country. Our neighbors in Missouri still 17 cents a pack. At the same time as we know all this, there's a lot of unanswered questions when it comes to how to maximize the effectiveness of tax and price policies in reducing tobacco use. One of the questions I had long gotten was whether or not the effectiveness of the tax eventually starts to wear off as taxes are higher. We have a lot of research on cigarette demand, but we have very little information about how other tobacco product use responds to changes in taxes and prices. Tax avoidance, tax evasion is probably the biggest barrier to raising taxes across states. And then we also don't have a lot of information about other non-tax related pricing policies. And as part of this program, our projects have been trying to address some of these questions. So when we start to look at what we've learned about the demand for tobacco products and the role of price, one thing that we've learned is that as price goes up, as tax goes up, we actually see smokers getting more and more responsive to price. So I think the opposite of what a lot of people thought, where you'd end up with the tax effects wearing out over time. We see it in the work that we've been doing with state-level data, and we see it in the work that we've been doing with individual-level data on smoking prevalence. So tax and price increases getting more effective as tax and price goes up. We've learned a lot about how states tax other tobacco products. I think the one thing that has become really clear is that states take a while to catch up to what the tobacco industry is doing. And as new products emerge in the markets, states either haven't taxed them at all or it's taken them a while to catch up to it. These are some of the data that we have from 2014. You can see at that point there's only one state that taxed e-cigarettes. We're up to a few now, but most states aren't taxing those products. Only about half of states are taxing the dissolvables. And then you can see some of the variability across other types of products. The other thing that's been happening with these taxes is that they've been changing. So in the past, most of the other tobacco product taxes were levied as a percentage of price. What's happened is that states have moved away from those to what we call specific taxes, or taxes that are based on weight. And we've been looking at the implications of that for prices and for tobacco use overall. The one thing that we have learned is that other tobacco product demand responds to price as well. So it's not just cigarette demand, but we actually see bigger effects of price on other tobacco products. Liz talked about e-cigarettes. We put out the first study looking at the demand for e-cigarettes. We saw that their demand was probably 3 times more sensitive to price than regular cigarette demand. What we've been seeing, though, is also some mixed evidence on substitution across other tobacco products, which I think is a little bit different than what some of the older evidence suggested. So we do see substitution between similar products. So cigarette taxes go up, little cigar taxes don't. We see people substitute to little cigars. But what we're seeing is that there actually seems to be some evidence of what we call complementarity between smoked tobacco products and smokeless products. And I think that part of that is in the way that these products are being marketed as a way of getting around things like smoke-free policies, so you can keep smoking if you're in an environment where you can't smoke, or you can keep getting that nicotine when you're in an environment where you can't smoke. Tax avoidance, tax evasion, like I said, a big concern of states, a big barrier to raising taxes. Some of the work that Matthew and I did as part of an IOM committee showed that tax avoidance, tax evasion has been increasing in the U.S. over time, and it's really increasing in response to the increasing differentials between states when it comes to their cigarette taxes. And you can start to see the big beneficiaries are some of the very low tax states that are near high tax jurisdictions. California actually gets more additional revenue from illicit cigarettes than any other state in the country. And then you can see some of the other states where this is really a problem, where there's a lot of illicit cigarettes coming into the market and where a lot of smokers are avoiding taxes. So one of the things that we've done in a couple of these projects is to try to take advantage of the tax stamps that states have to look at how much tax avoidance, how much tax evasion is occurring. So we can look at whether or not the stamp on the packs where we're finding them matches the stamp in the place where the cigarettes are being sold or where they're being smoked. So in one of the projects, we went out and purchased cigarettes across the country. This was a project where 2,150 packs almost were purchased, basically looking at Marlboro and Newport cigarettes. And at the end of the day, what this showed was that at least when it came to retailers selling to customers that they didn't know, that they were selling them legitimate packs, that there was very little evidence of tax evasion in this sample, and very little evidence of counterfeiting. But that may be because the people that are selling illicit cigarettes only sell them to the people that they know. They're not going to sell them to the researchers that are coming in there to buy the packs. And it may be that there's a lot of other activities happening through the back of somebody's van or something like that. So one of the other things that we did was to go out and collect littered packs across the country. We ended up picking up 3,840 littered packs across the country, 139 different communities in 36 states. We have to focus on packs with cellophane because the stamp is applied on top of the cellophane. And what we found at the end of the day was that the estimates that we got for tax avoidance, tax evasion from this are a lot higher than what you get out of most of the estimates that we had before. So it looks like at least 1 in 6 packs about is avoiding the tax at the local level or at the state level. What we tried to do was to distinguish between tax evasion and tax avoidance. So individuals, cross-border shopping versus more organized smuggling sorts of activities. And it looks like about half of what we saw, at least based on the distance between where the stamp that we found was from versus what the stamp should have been in the location where we found it. It looks like at least half of these are illicit trade in cigarettes, relatively small amounts that result from individual tax evasion. So part of what we've been doing is trying to figure out how states can deal with this problem, what sort of policies they're adopting. We've been looking at their stamping policies. Even given the really positive experiences in California, we see the states are lagging behind. They're not taking advantage of the new technologies that are out there that make it easier to detect illicit packs. We see that reservation purchasing is a big part of individual tax avoidance, so we've been looking at what states can do to deal with reservation purchases. You can see that this is a really big issue in places like Arizona, New Mexico, Oklahoma. So we've been looking at how states deal with tribal tobacco sales. And what we see is that a lot of states have really taken a fairly aggressive effort to try to reduce the sale of untaxed or low-tax cigarettes on tribal lands. So many states have negotiated compacts with the tribes to get taxes or prices up to levels on the reservation compared to what they are off the reservation. And they've been using a variety of other approaches as well. And we see some evidence that at least some of these approaches, particularly the compacts where they apply the tax to all the cigarettes that are being sold on the reservation, end up being the most effective. So states like Oregon, even where there's a significant tribal presence, have relatively few smokers buying cigarettes on reservations. So Oregon, South Dakota, Michigan, some of the states that are most effective in this area. And again, we've been focusing on non-tax pricing policies. There are some reasons that we can think of these non-tax pricing policies as potentially having a bigger effect on at least some tobacco users than tax itself. So there's a couple of different options there. The first one on the left is a minimum markup type of policy where it's going to push all prices up by some fixed percentage. And that's going to be different than a minimum pricing policy, a minimum floor price type of policy like Chicago recently adopted, like New York's adopted, where you set a floor price, a relatively high floor price for all cigarettes. That's going to have a big impact, particularly on people that are buying cheap brands. Then you can think about price promotion brands where you're targeting some of the industry price-related marketing strategies. So again, we've been trying to document what these policies look like across the states, how they vary across the states, and then what impact they're having. We have some new research that's coming out that shows that the minimum pricing policies actually are effective in raising prices, and they're effective in raising prices at the low end of the market, exactly like you would expect they would be. And then some of this information has been factored into then looking at what the potential impact of these policies would be on tobacco use if you set high minimum pricing policies across the states. And I think this highlights one of the points that Liz was making. This can be a very effective strategy in starting to reduce some of the disparities that we see between low and high income populations. So you know low-income populations relatively sensitive to price. Low-income smokers are smoking some of the cheaper cigarettes. If you can reduce the availability of those, push up price, you can have a bigger impact there. So this is looking at how different populations' prevalence would be affected as a minimum pricing policy would be effective. We see bigger reductions in prevalence in the lower income groups and even bigger reductions in consumption in those groups. The other thing we've learned is that a minimum price policy is not a minimum price policy, that states do this in very different ways, and a lot of states have a lot of exceptions in these policies that make them effectively useless in terms of actually raising price. So they allow trade discounts, they allow price promotions, things like that are going to reduce price below that minimum price, and as a result, the policy has no teeth. So again, we've learned a lot over the last 5 years in terms of how tax and price can be used to more effectively reduce the demand for tobacco products and all the consequences that come from that. But I think we also have a lot more to learn going forward. So the emergence of all these new products, the potentially different risks from using different products, I think opens the door for starting to think creatively about how differential taxes can be used to promote shifting away from the most harmful products towards the least harmful products, while at the same time preventing kids from taking up the use of some of these products. I think we still have a long way to go. We're starting to scratch the surface when it comes to tax avoidance and tax evasion, but still a lot more to learn there. And then I think when we start to get into the issues around vulnerable populations in particular, how does this affect tax increases, affect household spending? What's being used for tobacco that wouldn't have been spent on tobacco in the absence of that tax increase in low-income households where they continue to smoke? How do we reach some of the most vulnerable populations, people with mental illnesses? It's something I think we have no idea about at this point. And then for me, looking at how we take the tax revenues that we get. We know when taxes go up, revenues go up. How can we use those most effectively to optimize the effects of those tax increases in further reducing tobacco use? So whirlwind tour, you can follow up with me and find out a lot more about everything we're doing. And I will turn it over to Lisa now.
Thank you. I'm Lisa Henriksen from Stanford Prevention Research Center. It's my pleasure to present on behalf of several colleagues what we've learned about the retail environment for tobacco under this initiative. In this television ad for Tobacco-Free California, the narrator begins by telling us that we asked these kids to look at some products that were purchased at a nearby store. The ad cleverly illustrates that watching kids grab tobacco like Halloween candy convinces us how attractive these products are to youth. But the point of this presentation is to illustrate that nearby stores are numerous and much closer, much more nearby than you would expect. And under this initiative, state and local partners have better evidence and new tools to develop policy solutions for this problem. In a single year, the major tobacco companies spent $8.6 billion on marketing at the point of sale. The point of this investment is to make their products as visible and as inexpensive as possible. The preponderance of products and brands, low prices, and visible ads encourage youth and young adults to start smoking and make it difficult for smokers who want to quit to try and to do so successfully. What we've learned under the SCTC initiative is new evidence about the quantity and location of tobacco retailers, especially with respect to priority populations. I'll also describe some new information about change over time and neighborhood disparities in retail marketing from the first representative sample of U.S. tobacco retailers, and try to illustrate new tools that were developed to inform policy change. Let's begin with how many and how close by. We estimated that there are 375,000 tobacco retailers in the U.S. This is 28 times as many stores as there are McDonald's. This is almost as many stores as automatic tellers, which raises a concern about why products that are used by just a fraction of the population need to be as accessible as cash. 44% of U.S. teens ages 13 to 16 attend school within 1,000 feet of at least one tobacco retailer. Nearly as many live within walking distance, that's a half mile, of at least one tobacco retailer. But this is most common for African American teens. And adjusting for race, this is also more common for teens who live in low-income households. Dr. Genexi pointed out some important tobacco use disparity data for priority populations, and this initiative was first to discover that tobacco retailer density in U.S. census tracts increases as the proportion of households with same-sex couples increases. And for couples that are male-male households, this disparity persists after controlling for other neighborhood demographics that would be associated with a high concentration of tobacco retailers. Also for persons with serious mental illness who clearly use tobacco at much higher rates. We learned from a study that was recruiting smokers for a cessation trial that compared to the typical San Francisco Bay Area resident, adult smokers with SMI live in neighborhoods with 2 times greater density. And those who live in those areas with darker colored red compared to the ones who live in the areas with lighter color pink reported that they have a significantly higher nicotine dependence and are much less confident about their ability to quit. Let's go inside the stores. I mentioned the first nationally representative sample of tobacco retailers. We visited 2,200 stores in 97 counties 3 times since 2012. We documented this exponential growth in the availability of e-cigarettes from 35% of stores in 2012 to 80% in 2015. Half of the stores we visited displayed these products right on the front counter. This trend coincides with increase in marketing techniques that appeal to youth. More signs, a greater presence of signs at children's eye level, and a greater presence of tobacco products near candy. The flavored little cigars that appeal to youth are prevalent in all years, so these data are only for 2015. 85% of stores sold flavored little cigars and cigarillos. 81% sold them as single items, often at prices considerably less than $1. This practice is more common at stores in neighborhoods with a high proportion of African American residents nearby. They're more likely to sell flavored cigars. They're more likely to advertise tobacco on store windows and outside. They're more likely to offer discounts on the most popular brand of menthol cigarettes. This is an equity that needs policy remedies. The Aspire team surveyed tobacco control program leaders in all 50 states 3 times since 2012. Data not presented here indicate that retail activity, policy activity around this environment nearly doubled in the first 2 years. In 2015, this figure illustrates that more than half of states were working on priority policies around e-cigarettes, around density reduction, around non-tax mechanisms to increase price that Dr. Chalupka was just talking about. And this initiative has created new tools to help these efforts. One innovation is an agent-based computational model. This simulates smokers traveling through different types of communities purchasing cigarettes. In this particular example, it tests the impact of eliminating retailers at varying distances from schools on the overall cost increase, not just the price at the point of sale for the pack, but also in the acquisition, the time and travel effort. We learn that this cost increases most in urban poor neighborhoods, which suggests that they would benefit from such policies. Another innovation is the creation of STARS, a standardized tobacco assessment for retail settings. This was an extraordinary collaboration between researchers, government agencies, advocacy groups, public health attorneys, and 5 state tobacco control program leaders. This is a 10-minute observation, a 2-sided form, less complex than a computational model. It only takes a pencil and a clipboard. But it allows state and local partners to record their own real-world data about product prices and placement and packaging, as well as store characteristics, the availability of alcohol, the presence of WIC and SNAP, for example. This was released in June 2014, and case studies with states that were first to use this instrument suggest that it had filled a really important void in the literature and in practice. The previous instrument like this one had not been updated for more than 10 years, and no instrument has previously been designed to address policy concerns in the way the items on this instrument were selected. I'm going to end with an interesting example of cross-site collaboration in this initiative. Researchers working on smoke-free casinos and those kinds of policies in Indian country recognize that casinos are, in fact, many of them, in fact, also tobacco retailers, and developed an instrument to study tribal commercial tobacco, a module for STARS. This instrument is innovative in that it has a checklist of 80 brands, including tribally manufactured brands, and has been pilot tested in 3 states. They learned many things. One particular note is that they learned that some tribes will not enter contracts with tobacco companies and therefore forego money for promotions and shelving space that is attractive to other retailers in non-tribally owned stores. In short, and to finish, what we've done in terms of the retail environment, I hope, is strengthen the evidence base about which priority populations live near tobacco retailers and how this environmental exposure can exacerbate disparities in use. We provided benchmark data from a representative sample of U.S. tobacco retailers that highlights target marketing practices, particularly in African American neighborhoods. And we created new tools that I hope will increase state, local, and tribal capacity to regulate this problem.
Great. Thanks, Lisa. Thank you very much. I'm happy to present some of the data from the initiative that really focuses on new products and young people. And this presentation includes work from Sherry Emery and Xu Hangzhu. If I can get this to work. So the problem here we're going to focus on is young people using tobacco. We know that over 3,800 youth start smoking every day in the United States, that 80% of young people will smoke their first cigarette before the age of 18, and 99% will start before the age of 26. We also know that previously, when we've been thinking about tobacco use, we've typically thought of one thing, the cigarette. But of course, nowadays we have to deal with, as mentioned, smokeless tobacco products, snus, e-cigarettes, hookah, e-hookah, little cigars, cigarillos, and a wide variety of products. We also know that the media landscape in which our young people live is vastly different with social media and other devices. And we also know that tobacco use continues in social environments, and that light and social smoking and the co-use of tobacco with other products is continuing to increase. So what has SCTC research done about these new products and new challenges? I'm going to show you a couple of studies we've done that are really addressing new issues. So this is a study done by Xu Hangzhu looking at e-cigarettes. As mentioned, this initiative actually sponsored a special issue of Tobacco Control with some of the new research on e-cigarettes when they were just coming out. And this is an example of a more recent study where he looked at not all e-cigarettes, but really the difference between closed systems and open systems. So the closed system e-cigarettes are the first generation ones that look like cigarettes, and the nicotine liquid comes in a cartridge that's pre-filled. The open systems are the ones on the right here that look more like pens or tanks, and these you can fill your own nicotine liquid, and so they're open systems. So this study did a survey of smokers who are using e-cigarette users, and asked them about open system use and closed system use. And this is an adult study, not a youth study. But what it found was that former smokers were more likely to use open systems than current smokers, and that current smokers who had made a quit attempt were more likely to use these open systems than the closed systems. So clearly an e-cigarette is not an e-cigarette, and some of these newer products as they evolve may have a different relationship to smoking cessation than the closed systems that look like cig-likes. Another example of e-cigarette research is actually looking at e-cigarette presence on YouTube. So this is a study done by Sherry Emery, where she looked at e-cigarette videos on YouTube and, maybe not surprisingly, found a whole lot. So over 28,000 e-cigarette videos were found from over 10,000 accounts between 2012 and 2013. And there were tons of engagement, over 100 million views of these videos, ratings over 300,000 times, and with 280,000 comments on the videos. There's also more and more videos on YouTube, with more than 2,200 new videos uploaded each month. And really, she has here the top 1% are winning. So the top 1% of the most viewed videos actually makes up almost half of the views. So there's really a concentration of what's being viewed. And then within the content of these e-cigarette videos, lots of marketing. So about 70% of the videos actually link out to websites. There are lots of references to health, safety, smoking cessation, and then about a third of them have a reference to brands. So the marketing in these videos are really integrated. Sherry also did a study looking at Twitter. And again, e-cigarette presence on Twitter is huge. And this is data from over 3 years now, where she found about 2 million tweets on Twitter per year related to electronic cigarettes. And about half of these tweets are marketing and commercial accounts. She has found that the purple line there, the organic sort of user-generated tweets, have been increasing over time. And also celebrity and influential users' tweets are increasing over time. Clearly, this is a space where we need to be. And then even bigger than e-cigarettes on Twitter, she also did a study on little cigars and cigarillos on Twitter. So the prior study showed about 2 million tweets per year on e-cigarettes. This study found over 4 million tweets on little cigars in just 3 months. So there's an enormous presence, and little cigar sales have been going up in the past 4 years. About 17% of these tweeters are influential, meaning they have at least 1,000 followers. And most of this also appears to be user-generated, so only 1% of the Twitter accounts are overtly commercial accounts, although you also have mavens and people who sort of have a brand on Twitter that may be generating some of this. She also found, interestingly, that over 80% of these LCC little cigar tweets contain references to marijuana, so really when you're out here on the cutting edge with youth and their little cigars, you're also seeing this co-use of tobacco and marijuana very frequently. So things to think about here in this space is that certainly the tobacco industry is using both kind of formal and informal cultural engagement and this really aggressive subculture targeting on social media. And they're also we also see tobacco as sort of riding the coattails of marijuana liberalization and normalization. And many of those who are using tobacco products to deliver marijuana may not even perceive that they're using a tobacco product. There's certainly need for monitoring and regulation of the commercial content in social media. And this is an important source of exposure to tobacco marketing. So if you use kind of typical measures of ad placement expenditures, you may miss this. So we also continue to have tobacco use in social environments like bars, and you've heard a lot now about all the marketing and all the tobacco industry is doing. So the question is, what can we do about this? And we have been funding a study which is exploring how can tobacco control efforts compete with the tobacco industry in social environments and on social media, and really tailor those efforts to specific subcultures like alternative music hipsters or the partiers. And I'm going to show you an example of the interventions that we're studying in this space. Where's my audio? Someone was testing the audio, and now it doesn't work.
Havoc and Commune are campaigns to reduce tobacco use among young adults. Both utilize the social branding model to associate healthy behaviors with peer crowd values. Havoc and Commune use bar events, direct mail, social media, digital campaigns, and influencers to deliver their messages. Havoc focuses on partier values by showing how tobacco use affects dating, physical appearance, breath, and sexual stamina through influencers like DJs and party promoters. Commune shows how the tobacco industry goes against hipster values by harming the environment, animal testing, and contributing to world hunger through original pieces developed by local artists and fashion designers. While each campaign focuses on different values and influencers within each peer crowd, they both rely on the power of social identity to shift cultural norms away from tobacco use.
Yeah, So as part of this initiative, we've published 4 evaluations of this strategy, which are all preliminary studies, but we have found that this commune, hipster-focused intervention has significant decreases in smoking. The Partier brand was associated with significant decreases in daily smoking, though it didn't do much on non-daily smoking. We also did a secondary data analysis of the LGBT brand, which was not in the video, called Crush, which also showed the highest levels of exposure to the intervention were associated with the least amount of smoking, and that brand recognition, liking, and understanding is associated with smoking behavior. So the big controlled trial of this, we're just completing data collection, but certainly these 4 preliminary studies look quite promising for this ability to compete with the tobacco industry. So bottom line is that we're continuing to have lots of work to do, but e-cigarettes and new products need to be researched continually, and some of the newer products may be more effective for smoking cessation. We certainly know in social media, e-cigarettes have a large presence, but also little cigars, marijuana, and all the kind of leading edge of tobacco use and other product use is going to be in this space, and that branded interventions may be able to compete with marketing campaigns, and certainly we look forward to doing more work in this area. Thank you.
Hi, everyone. So I'm going to be talking about 2 of the SCTC projects. One focuses on smoke-free homes, and the other focuses on smoking cessation. And so I'm presenting Shuhong Zhu's work as well as our own. So generally speaking, starting with smoke-free homes, we have good news about secondhand smoke exposure. If you look at the last 15 years or so, we've seen significant decreases. So in 99-2000, about half of U.S. non-smokers age 3 and over were exposed to secondhand smoke, and that's decreased to just a quarter of the non-smoking population, which is good news. Unfortunately, though, there are some disparities and problems remaining. First of all, 1/4 of the population of non-smokers is a lot of people, so that's still 58 million people that are being exposed. The home, as Liz mentioned, is now a major source of exposure and harder for us to regulate. Because the home is a major source of exposure, children are the group that have the highest exposure levels now. So 45% of children aged 3 to 11 are still exposed. And with many topics in public health, there are significant disparities here based on income levels as well as race, ethnicities. So there's still some work to be done. If you look nationally, about 83% of households now have a household smoking rule, which is great. About 90-some% of households where it's all smokers have a rule. But if you look at households where there's a smoker, it's 46% are smoking outside. The rest are still smoking in the home. So there's work to be done. There are disparities in terms of who has smoke-free home rules as well, by income in particular, as well as race, ethnicity. So what did we try to do to learn a little bit more about this area? First of all, we had an innovative partner. And so we partnered with 211, which is like 411 or 911, except for social services. So people call, or now go to websites increasingly, to get assistance with linkages for basic needs, such as paying for shelter, heat, electricity, and food. It's a national infrastructure, loosely connected national infrastructure, typically run by United Way agencies, but not completely. There's over 200 of these centers operating in all 50 states. And so it's a really strategic partnership for public health in reaching low-income populations, which is where a lot of disparities lie. Then we decided to develop a simple intervention. And the reason we wanted to go simple was so that it would be easy enough for partners to implement. And so we did that. We tried to develop an intervention that was scalable, that would have high potential reach. We came up with a 6-week intervention with 3 mailings and 1 coaching call, delivered at 2-week intervals. And so here's just some of our materials. If you look closely, you can see things that are better outside. Our theme is some things are better outside, and there's cigarettes, which are better outside, along with other things. We have a 5 steps to creating a smoke-free home. We have a challenges and solutions booklet based on qualitative research. And we have a photo novella, or a story about a family negotiating a smoke-free home, and then many other materials as well. So we did a randomized controlled trial to find out if this worked, and yes, it did. So the intervention participants, about 30% of them were smoke-free or had a smoke-free home rule at 3 months, and that went up to 40% at 6 months, in contrast to the control group who had lower levels of folks going smoke-free. That was statistically significant. We validated their self-reported smoke-free home rules with air nicotine monitors just to see if they were telling the truth or not, and they were, which was good. And then we followed this with 2 more studies. We did replication studies. So in the Atlanta trial, which was the first one, and I should say we partnered with United Way of Greater Atlanta 211. In that study, we actually delivered the intervention. So we had university staff delivering the intervention. And then to make this more practical and make sure it would work in the field, in the second 2 studies, we partnered with North Carolina 211 and Gulf Coast 211 in the Houston area. And 211 staff delivered the intervention. And we were somewhat surprised that it actually worked just as well and even better when the 211 delivered the intervention than it did when we delivered the intervention, which is interesting. We were also interested in, will this have any positive impact on smokers? And we did see a decrease in cigarettes smoked per day in the intervention group relative to the control group, and we saw that in all 3 studies, which was nice. So now we had a successful research-tested intervention, and our last phase, which we're in right now, was to actually disseminate this intervention through 211s nationally. So we put out a call for potential partners, had a great response. 31 211s across the country wanted to partner with us. They did get $70,000, but still they wanted to partner with us. We funded 5 211s, and those are Orlando, the entire state of Alabama, which is multiple 211s working together, Tulsa, Akron, and Cleveland. And they collectively have recruited 2,000 households that allow smoking in the home. We're really excited about that, and we're also excited about the number of smoke-free homes we'll be creating as a result of this. So that's what we've done with smoke-free homes. The initiative has also done some neat work in smoking cessation, and Dr. Shu-Hong Zhu is the lead of this. Most of our anti-tobacco media campaigns target smokers, but if you think about it, non-smokers play a really important role in establishing anti-smoking norms. And so his project capitalizes on this and explores whether non-smokers might be able to help smokers quit. So what did they do? They conducted a 3-arm randomized controlled trial. They recruited over 3,000 pairs of smokers and non-smokers, and similar to our project, they used 211 to do that. So they partnered with 211 in Oklahoma and California, were successful in recruiting large numbers of folks, randomized them into 3 groups. One group was targeting the smokers with 10 mailings, another group was targeting the non-smokers in that dyad with 10 mailings, and the third group was a more traditional control group with no materials. They sent 10 mailings to the 2 intervention sets, and they were trying to replicate media exposure where it was over and over and over. So there were 10 contact points with the intervention households, and they had messages like never, never stop trying, and it's really hard to quit, but keep trying. And all of their materials included DVDs and pamphlets and things like that, lots of different things, sorry. And they had a call to action in each of these as well. So that project worked as well. Targeting non-smokers was just as effective as targeting smokers directly and helping smokers quit, which is exciting. And they concluded that non-smokers are a largely untapped resource in tobacco control, and that we could do more to mobilize non-smokers to help smokers to quit. So in summary, both teams developed relatively simple interventions, which worked. 211 systems, both projects partnered with 211s, and that worked really well for reaching a low-income population. In our project, we learned that both smokers, which you might not expect, but smokers and non-smokers were able to work as the change agents in creating smoke-free homes, and non-smokers also have a role in assisting smokers to quit. So what's next? I think we're looking for partners to implement these programs through systems. I think that'll help make a difference. We're also adapting these interventions for new populations and new partners. In particular, we've started adapting the intervention for American Indians and Alaska Natives with our project. So, thank you.
Thanks, Liz, Frank, Lisa, Pam, and Michelle. Really a great overview of SCTC research over the past number of years. And next we'll be hearing from representatives of SCTC partner communities representing federal agencies, state governments, and tobacco control policy advocacy. Each speaker will share their experiences collaborating with SCTC investigators and using SCTC research to support their efforts. They will also enumerate priorities for additional research to support and expand state and community tobacco control research to achieve long-term goals of reduced tobacco use and exposure to secondhand smoke. Our speakers are first Dr. Corinne Graffunder, Director of the Office on Smoking and Health in the U.S. Centers for Disease Control and Prevention, which is the lead federal agency for comprehensive tobacco prevention and control. Dr. Graffunder is responsible for providing broad leadership and direction for all scientific, policy, and programmatic issues related to tobacco control and prevention for the office. Following Corinne will be Ms. April Raisler, Chief of the California Tobacco Control Program, where she has served in various leadership roles since the 1989 inception of this model state program that has achieved remarkable success in driving down tobacco use rates, protecting non-smokers from the harmful effects of secondhand smoke, and changing tobacco-related social norms throughout the state. Ms. Tracy Strader, Executive Director of the Oklahoma Tobacco Settlement Endowment Trust, a state agency established by popular vote 16 years ago, and uses the Master Settlement Agreement funds to improve the health and quality of life for all Oklahomans, will be speaking next. Ms. Strader's work includes developing and supporting accountable programs and services that address the hazards of tobacco use and other health issues in Oklahoma. And we'll conclude that section with Mr. Matthew Myers, President of the Campaign for Tobacco-Free Kids, which, since its founding 20 years ago, has been the leading non-governmental voice for tobacco control in the U.S. and internationally. Mr. Myers himself has been involved in virtually every major national legislative effort over the last 30 years, including the Family Smoking Prevention and Tobacco Control Act of 2009, which gave the FDA jurisdiction over tobacco products. Let's begin with Dr. Graffunder.
Thank you, Todd, and good afternoon, everyone. It's really wonderful to be here with all of you, and it's wonderful to be able to be the first to shift the conversation a little bit and go from the research and the findings to actually the utility of the findings and how the significance of this body of work. And I will say just out of the gate that every study, all of the research that was just presented to you is all valuable to the work that we do in our National Tobacco Control Program, to our stakeholders, to our partners. So I apologize in advance to those of you that I am not going to call out directly because I only have so much time, and so I'm not going to point to every study, but just trust me when I say that this type of research and the value, the practicality of this research is very significant for an agency like ours, where we have programs in states and communities where they're trying to actually affect public policy and really affect the, what's happening at the local and state level. So with that as a little disclaimer, I'm going to jump in. Let's see, get my clicker going here. So Liz started out by talking about 1964, and I'd actually like to start out by talking about 1964 as well. And I'd like to ask you to think, if you were alive, and if you can remember 1964, I want you to think about what it was like then. About 50% of the adult population smoked. Rooms, offices, public spaces were very, very smoke-filled. We had our Tips from Former Smokers campaign ad participants here last week, and one of them shared that at the great age of 8 years old, he would go to the local convenience store and purchase the cigarettes for his father. And that was completely easy for him to do, completely legal, and they were very low priced. And we had lots of advertising on television, and we had lots of cigarettes in movies. So we have actually come a long way. We recognize that. And the 50th anniversary report released in 2014, well, the 2014 report was significant, not only in summarizing everything that we have learned and the progress that we have made, but also clearly calling out that there's still a lot of work to be done, but also importantly, acknowledging that we actually know what works. We have programs and policies that we have put into place that have been proven to be effective in addressing tobacco. And coming from the CDC, I like to think of how envious we are of our infectious disease colleagues, right? So we know that they have vaccines, and they know their vaccines work. They know that they can rely on a consistent impact for the most part. So their big challenge, of course, is how do they reach the biggest, broadest number of people, and how do they actually get the protection that's needed put into place through these vaccines? Now, I would suggest to everyone here, we also actually, in tobacco control, we have a vaccine. We actually have one, and this is what it is. We know what works. We know that if we fully implement 100% smoke-free policies, if we focus on and equitably address pricing, if we provide and encourage and continue to support cessation, and if we focus on hard-hitting media, that we actually can drive down the numbers that you've already heard from lots of the speakers. I want to start from a public health perspective by speaking for a second about place-based initiatives. By design, place-based initiatives, they work in communities where we work, where we live, where we play, and they are designed to support places that promote and encourage good health and well-being. So the retail environment. The retail environment is a wonderful and important, as already has been stated, place for the tobacco control movement to be working in, to really understand how we begin to look at the inequities, how we understand the marketing and the targeting from the tobacco industry. I'm not going to repeat the data that's already been shared, but just really the amount of resources that the industry is putting into point-of-sale marketing should suggest to us that we need to be concerned about point-of-sale marketing. So as has already been shared with you, the STARS work, the work in terms of assessing and the standardization of this tool that allows our grantees then, our partners, to be able to consistently collect meaningful data in a way that then they can take and they can both understand what's going on in their communities, but then also take that to their community policymakers, take that and use that in communities. And what we know right now is we know that there are 40+ states that are using STARS, and it's being used in dozens of communities within those states. So we look forward to continuing to work with this tool, continuing to support our programs, and really continuing to see how this type of data collection does in fact help advance ongoing policy action. You also heard about excise taxes already and heard about pricing. And what I really wanted to, just basically fundamentally say is that we do know the single most important thing that we can do to really prevent tobacco use and to also help in terms of decreasing the rates of use are to increase the prices. You heard Dr. Chalupa talk about this, and his work and the work of many of the economists across tobacco control economists across the country really do a couple of things for us. Certainly they help with understanding the situation, monitoring and tracking what is going on. But I think really importantly from a national program perspective, they really help give that credible voice and the credibility to the messaging that, again, our state and local partners can then take to their decision makers and take to the policymakers with the credibility of the academy that comes behind this research is just really something that's very, very powerful and very important to our programs. Again, everybody covered my talking points so wonderfully that you made this very, very easy for me. So the disparities, again, secondhand smoke. We have seen tremendous progress in secondhand smoke in terms of reducing exposure for non-smokers, and yet we see disparities. We see disparities in where we still have work to be done. There, I think, are 15 million children of the larger number of the non-smoking population that are still exposed to secondhand smoke in this country. We see the differences in terms of populations that are at risk. And as already has been said, we also see that we are making progress. We're making progress at the state level, at the local level, cities, et cetera, counties, that are working in the smoke-free air arena. And while this is good, and if I showed you a 2000 slide versus the 2012 slide or whatever this is here, 2016 current, we have made tremendous progress, but we also, what may not be as clear here is that we still have 50%, a little over 50% of the US population that is not covered by comprehensive smoke-free policies, meaning work sites, restaurants, and bars. And again, not to overemphasize the disparity piece, but to overemphasize it for a second, when you look at the workplaces that remain less than optimally protected, when you look at the communities that remain less than optimally protected, and when you look at geography, just the simple geography of where we still need to work to have adequate smoke-free protection, we still have a lot of work to do here. And again, so the SCTC research is significant in helping us both understand and then creating the tools and the science to really help address these gaps. So this is the research that you just heard about, the research that Michelle and her colleagues did in terms of smoke-free homes and smoke-free home policies. And very practically for CDC, what this is helping us with right now is it's helping us with the work that we're doing with our colleagues at HUD, because they're in the process of rulemaking. They're in the process of moving towards smoke-free public housing, and they are looking to their public health colleagues to help them understand how are they going to implement this, how are they going to provide cessation support, how are they going to evaluate the impact of this policy. And so we are actively engaged with HUD, working with the public housing authorities, and we are using and relying on, again, this kind of research, these kind of data to really help us both understand and really bring the newest and most innovative strategies to that body of work so that we can really help those communities feel like they are being supported as they go through the implementation. Now I want to touch on tips from former smokers for a second and talk about media campaigns. What many of you may not know is that it was SCTC research that also helped us understand the significance of how best to address the needs of current smokers. So it was SCTC research that helped us understand that these graphic messages actually would really kind of create a visceral response, right? An emotional response that would help smokers grab their attention, and really focusing on the fact that while an individual may die from a smoking-related condition, 30 people live with smoking-related disease, disability, and have some, life-altering circumstance from their smoking-related behavior. So SCTC research really helped us understand not only the graphic part, but also the personal testimony part, that by hearing from real people about their real life experience was something that would be impactful. And as you saw, I think there was a slide there, there is tremendous response. We're in year 5 of the Tips from Former Smokers campaign, and in the 5th year, we are seeing a response to our campaign that is equal to, if not greater than, the other individual years in terms of really getting smokers to continue to call those quit lines and respond to these ads. So we know that smokers in that moment, when presented with a compelling advertisement, are actually motivated to take some action. So finally, to wrap up, in terms of going forward, the way we have, and again, you've heard about it from a lot of the speakers already, so I don't have to go into this into great depth, but we recognize that a lot of we know what works, but we also know that innovation occurs at the state and local level. And so we are looking at the innovation in things like Tobacco 21, and how do we understand all of the contribution that something like Tobacco 21. We totally are with you all in really trying to understand the changing landscape and understanding how do we make sense of and what are the highest priorities for us to focus on in terms of the changing tobacco landscape. And then lastly, this idea of, again, place-based and just the Affordable Care Act was mentioned. I mean, how do we take advantage of and how do we continue to understand the opportunities and do this very practical research that helps us help our state and local partners and our funded grantees to really do the most evidence-based work that they can possibly do and get the kind of results that we want to continue to get. So with that, I'm going to turn it over to the next speaker.
Good afternoon. I'm April Raisler, and I'm the branch chief for the California Tobacco Control Program. And as you can see from the title of my presentation, I'm a big fan of the SCTC Research Initiative. So let me count the ways. You know, when you dial 411, you're calling for information, and I think the SCTC Research Initiative has done an outstanding job in pushing out information about their research, but also sharing PowerPoint presentation, testimonies, posters, and doing it really proactively. In addition, many of their investigators have wonderful websites that have been very helpful too. We heard when you call 211, you're calling that to go get help with resources. And what the SCTC initiative has done, they're not only publishing peer-reviewed articles, but they're actually providing real tools that people like myself can use at the state level or at the community level. So they're taking the research and putting it into reports and documents that practitioners can use. So the Aspire project produced some case studies about innovative work going on in Rhode Island and Massachusetts, and this is the case study that they did on pharmacies. And some of you would say, well, why doesn't Massachusetts or Rhode Island just produce their own case studies? But as a person who works in our local health or state health department, I can tell you we don't have the bandwidth sometimes to do this kind of high quality case study work. And what these case studies do is that they go beyond what the research tells you, and they're giving you the actual roadmap and the practical tips and the strategies to get there. They inspire confidence that I can do this too. And so we're building upon this work, and here's some examples of tobacco-free pharmacy policies that have passed in California. And then 911 is the number that you call for urgent help. I'm pretty sure every state has Frank Chalupka's number on speed dial, because we're constantly trying to raise tobacco taxes and need his help with testimony and figuring out what the impact of a $1.50 tax would be or a $2 tax. In California, we're really fortunate to have two SCTC researchers who live in California, Lisa Hendrickson and Pam Ling, who testify at city council meetings, before the legislature, at Board of Equalization meetings. People have shared information like Kurt Ribisol has this countertobacco.org website where they've been running this photo contest for a number of years, really putting a face and a picture to tobacco use in stores. We wanted to emulate that in California. Well, he shared all of his processes and procedures with us that made it so much easier to do. In California, we're running a large retail campaign called Healthy Stores for a Healthy Community, and we knew that our local health departments, they were talking about plotting how the proximity of tobacco retailers near schools. Everybody was doing it in a different way. So, you know, we got on the phone with Lisa Hendrickson, Kurt Ribisol, and put together a tip sheet. So people are just willing to share that kind of information. When we released an e-cigarette media campaign last March, you know, we knew that Pam Ling was, you know, an expert in working with young adults and with social marketing. So we vetted all of our ads through her. And then when we released our media campaign, the same day that we released the media campaign, all of the ads were ripped off, and there was a counter website put up called notblowingsmoke.org. We were getting 100 negative comments an hour on our Facebook page related to the e-cigarette campaign, which, you know, if you're government funded, that's not a great place to be, a comfortable place to be. So we contacted Sherry Emery, and I don't know, through some magical work that she does, she could tell us what was happening on Twitter and Facebook with these communications, which enabled us to create a defensive strategy and respond to that negativity. So one of the things researchers are always interested in is scaling their research and actually getting it implemented. So we were really intrigued in California with the Smoke-Free Home Project, but we wanted to implement it through clinics and social services organizations. And Michelle Kegler and the Emory University people have just been wonderful in terms of, translating that to a different kind of environment from 211. We have funded 7 projects beginning July 1st, which are reaching some really interesting populations, including, HIV positive and formerly incarcerated populations. When I talked to my colleagues in North Carolina, they said another value of the Smoke-Free Home Project was it gave them a new way to talk about smoke-free homes and messaging just in the broader community. So I think one of the great strengths of the SCTC project has actually been translating research methods. So this STAR assessment that Lisa talked about, it really was a huge paradigm shift from what we had been doing in stores previously. We had been counting ads and the type of tobacco marketing materials. It was very laborious. And then at the end of the day, what did you do with it? So this new tool, we're looking at the availability of menthol cigarettes, flavored tobacco products, pricing, cigar packaging, things like that. So we took that concept and applied it to this Healthy Stores for a Healthy Community campaign. And then we broadened our campaign to include food, alcohol, and now we're looking also at condoms. So this methodology has been transferred to California and it's been transferred to other content areas. The SCTC project has also done some great work for states that don't have tobacco retail licensing. Do you know how hard it is to figure out how many tobacco retailers you have? And you have to prove to CSAP that you actually have those retailers. So they came up with a methodology for states to use. So I know that researchers are always interested, are we actually using their research to inform policy and decision making? And I want to just reassure you that we are using your research for policy reports to prepare legislative testimony and bill analyses. So California may have a $2 tobacco tax initiative placed on its November ballot, which also includes taxing e-cigarettes. So we're getting questions from the legislature, and one of the questions was, what's the price elasticity for e-cigarettes? SCTC provided the answer. Thank you. We're also interested in translating, research to policy. And again, what the SCTC Research Initiative did, it just didn't publish peer-reviewed articles, but it told us how to make this information useful. And these are examples of policies being passed in California where we've expanded tobacco retail licensing to ban the sale of flavored OTP products, to restrict the size of cigar packages that can be sold, for density and zoning issues. So it's practical information that's coming out. So in conclusion for me, what the SCTC did, it went beyond just providing great research. You really improved data collection methods that can be used at the local level. You collaborated with practitioners at state and local health departments. You were transparent in your dissemination, and I think that you've actually set a new bar, a gold standard, and that other research initiatives need to look at that. You provided really practical stuff that we're interested in working on. And overall, you've just moved the ball forward. So in terms of continuing and unmet research needs, these are my top 10, but I'm just going to focus on a couple of things. So in California, we have our Healthy Stores for a Healthy Community campaign that's looking at the retail environment, and we're looking at tobacco, we're looking at the availability of fresh fruits and vegetables, we're looking at the availability of different alcohol products, and we're looking at the availability of condoms. Because there's a lot of things that promote or discourage health happening in the retail environment. So we actually need research that's going to get outside of the silos and give us and inform us information about whether those are facilitators working collaboratively or if there are barriers. Another issue in terms of, crossing the borders, Western states are really facing this issue of this interconnection between tobacco use, vaping, and marijuana use. There is an increasingly permissive environment for marijuana use, and we need research that crosses tobacco and the drug use world to inform policy and decision making happening in California and other states. So those are two things that I would encourage you guys to look at, how to put research initiatives that don't just look at tobacco but look at the broader environment. So thank you, and it's really been a pleasure being involved with the SCTC Research Initiative.
Good afternoon. What an honor and pleasure to be here today. I'm Tracy Strader. I'm Executive Director of the Oklahoma Tobacco Settlement Endowment Trust. Just for a quick background, after the settlement of 1998, and I must say, as I speak to groups, I'm amazed at how many people don't even remember the settlement. It's been a few years. But after that, our state did something really unique, and our voters approved a constitutional amendment that protects the majority of the settlement payments in an endowment. We invest those earnings, and then we spend only we invest those payments, spend only the earnings on tobacco control programs, cancer and tobacco research and treatment, and other health issues. That'll be important a little bit later in my discussion. In addition to our work in tobacco control, we do fund the Oklahoma Tobacco Research Center, which is part of the Stevenson Cancer Center. So you've just heard from April, and you just can't get much better than how California works with science and health practitioners across their state and other states. So I think it's important to just put into context. California's program's been well funded for about 25 years, although I'm sure they would argue we need additional funding. They've been a pioneer in this work, and we all owe them a debt of gratitude. I know we emulate California every chance we can. So California is a state of 38.8 million people. Oklahoma, by comparison, has 3.8. So we're a tenth the size in population. And we have only had what I would call relatively adequate tobacco control funding for about the last 8 years, as our endowment earnings have reached a level where we could actually put in place the major components of a comprehensive tobacco control program. And while California has a prevalence rate, I believe, of 11%, we in Oklahoma are celebrating a historic low of 21.1%. So this will give you a little idea about the disparity between California and Oklahoma, and part of what I'm here today to say is that any state of any size or with any amount of resources can access the SCT research and research like it. One thing we have in Oklahoma that's pretty different from a lot of states is we have preemption. And I think you heard earlier how the Family Smoking Prevention and Tobacco Control Act lifted that federal preemption on states and local governments to be able to take a lot of wonderful actions, particularly in the marketing realm. In Oklahoma, however, our state has passed a variety of laws that preempt local governments from passing ordinances or laws that are stronger than state policy. So we are in Oklahoma as hamstrung as the rest of the nation was prior to the implementation of that act. And I think after so many years of practice, I can pretty confidently say preemption has had something to do with our slower progress. So yes, the SCTC has made research accessible, I think, approachable to the average public health practitioner. When we know about what's going on, and I think that's our job, is to stay in touch, we can really make use of these resources, as April has mentioned. But also, the SCTC research scientists are great about reaching out and being proactive. We get to collaborate with the scientists, we use their resources, resources and help to disseminate findings. But one of the best things is that ideas from the field can percolate up to research. So that's why the title of my presentation is Research to Practice and Practice to Research. We really do try to work hand in glove. So I'll give you just a few quick examples. One relates to some of the work Pam Ling has been involved in. You saw some of those ads earlier. And we really needed a way to reach bar and club goers, I think is the way I would say that. Our smoke-free law does not give 100% protection. Most restaurants are smoke-free, most workplaces are smoke-free. So we really are limited to this bar and club environment, which is heavily influenced by the tobacco industry. They've been around for a long time. They scan driver's licenses in exchange for for that information. They may give you a coupon or free samples, and then they've got your contact information and direct market you to death. So we knew that we really had to do something to intervene. And we started working with Rescue Social Change Group on the Havoc project, and we had really tried to influence these club and bar goers. And this is really in our lingo, it's the partier crowd that we were trying to influence. And what we wanted to do is increase demand for smoke-free environments. I think one of the things Dr. Ling uncovered was the fact that in Oklahoma, they use a methodology where they'll show pictures like, are these the people you would hang out with? And in Oklahoma, we just didn't even have an image of a non-smoking partier that people would want to emulate. So we kind of had to create that. We had to start in the basics, right? And of course, you know, this is a population whose prevalence rate is extremely high, and we're hearing more and more every day of people that are starting to smoke in these college-age young adult years. Used to never have that issue. But because of this leverage, this collaboration with the SCTC, we were able to actually have a control site in Nashville, Tennessee, and which we would not have been able to do in the past. So we all know smoke-free is an evidence-based strategy, is an evidence-based policy. The different ways you have to get there when you're in a struggling policy environment may be innovative. When we want to put something innovative in place, it's really important that we study it. So this project allowed us to do that. The other thing, just in terms of disseminating this research, so we started with the Havoc project, and we really did make a difference, I think, in social norms and in creating demand for smoke-free bars. So we provided a grant to Rescue Social Change to start a different project called Free the Night. And I'm just so proud of this. If you want a real-life example of social norm change, I have to tell the story of Sip and Go, or Sipango. Sipango has been a bar that's been in Oklahoma City for, I think, 1,000 years. It looks relatively small here, but believe me, this is a trendy place to be these days. People walk and ride and do whatever they can to get there. Well, on the left, you'll notice that the first marquee sign says, "Smokers welcome." Well, right across the street from this particular club was another club that had live music, not loud, but live music, and they went smoke-free so many years ago, way before it was popular. So this smokers welcome sign for Sipango was a taunting of the patrons who went to the other bar. Now, because of Free the Night, they've been able to do surveys of their customers. They found that there was huge support for smoke-free. In fact, people said they would come more often if it was smoke-free. They'd made the decision to go smoke-free. This is a more recent sign about the Thunder Games and the NBA playoffs that the owner himself took for us because he was so proud. But the original one, they went smoke-free during a football playoff game, or sorry, I don't know all the football terminology. But nevertheless, we've gone from smokers welcome on the marquee to we are smoke-free and proud of it. And this particular owner says, wished I'd done it years ago. And this is exactly the kind of thing that we really need in our state. Project Best is the next. Oh, and I should say in Havoc, part of what happened was our TSET funding covered the intervention in Oklahoma, and then the SCTC funding covered the data collection in the control site. So we leveraged our resources in that way. Project BEST, you've already heard a little bit about. This was nice for us. Dr. Shuhong Zhu from California has been a good colleague and friend of ours for quite some time. California and Oklahoma both enjoy pretty robust quit lines, and so we were familiar with one another. And in this particular project, we were actually able to be involved with the scientists from the ground up. We worked with design, I think I may have had it here, design, messaging, the recruitment, and even with the dissemination of the findings. And of course, we're thrilled that we were able to show that intervening with non-smokers actually makes a difference with smokers' cessation. And just on a personal note, I'll mention that having seen the videos that go to the families as part of this project, I actually think it's going to save a lot of marriages and other relationships because it kind of shows you what to do and then what not to do very well, or what not to do and then what to do. Nevertheless, this really, I think, also demonstrates the important role that health communications and quit lines can play, even when smokers don't call a quit line. So, Shuhong has always had this theory that the quit line's very existence and then the promotion of it through marketing will impact smokers, even those who don't engage that quit line. And in this way of engaging non-smokers, we're even able to extend that reach further, and it is a huge untapped resource. We're excited to kind of unleash ourselves on it. But further, I think, 211, I guess, is just going to be the very best partner tobacco control may have ever seen as a result of all this great work. So we knew about Dr. Kegler's work with 211, decided to try to link it for us and for our recruitment. Recruiting smoker, non-smoker pairs in households is a little tough. And we were very successful as a result of this link with Oklahoma's 211. My agency, our staff had a relationship with them, so we were able to make that initial introduction. Then when the California team came to town, we could go to their board meeting and vouch for our partners, because we're not California. And so we were able to vouch for our partners, get 3,000 study participants very quickly. And now our Tobacco Research Center staff are working with that same 211 to integrate a smoking cessation strategy and actually do a connection to the helpline services. I've also heard Texas, I think, is going to be exploring the use of 211 around an asthma initiative with tobacco. So this is just expanding. Talk about diffusing innovation, or I think I called it infecting innovation. Let's see. Okay, stop. Sorry. So I think I'm already out of time. And I just do want to wrap by saying that the SCTC has been a phenomenal partner. We've definitely used Dr. Chalupka's work around the cigarette tax. And just most recently, our state has proposed a $1.50 cigarette tax. Philip Morris has recently been in town and proposed a 50-cent tax and using TSET funding to make up the difference. So I think you can see where the rapid response, I really do want to say I think the rapid response funding available in this project has just been critical. I think it's one of the few ways we really can get practice to research. And just in terms of future needs, I beg for more on policy, more on prevention, the poly tobacco use, and anything we can do to continue to link junior scientists with senior scientists so we can build capacity in the field. Thank you.
It must be next because I'm last. Let's go. Okay. No. There's the problem. I look at it from a slightly different point of view, and that is the point of view of an advocate with regard to these issues. So we are ultimate consumers, but consumers in a different way. People don't often think about the fact that advocates not only need evidence. to support our advocacy work, but we need evidence to support deciding what we should be working on. One of the unspoken themes of every speaker up to this point in time is that the whole reason we do what we do is in order to reduce the number of people who die from using tobacco use. And we will only do that if we have solid, objective, measurable evidence of the causes and what will be most effective in reducing tobacco use. And so while people don't think of how advocates look at this work in this way, it is absolutely essential to accomplishing the combined ultimate goal, helping us decide what we should work on, and then allowing us to work on it in a way that is scientifically based so that we set priorities correctly, use our resources wisely, and ensure that the actions that we take are not based on whim, anecdote, but are based on solid core evidence so that when we look back over time, we can be sure that we've had the greatest effect. Now, this project not only produces science, it puts together the other components that are necessary for a coherent whole to achieve rational public policy. It enables a combination of partners among advocates, government leaders, and scientists so that we can have a coherent whole in what we present and how we present it in a way that has the kind of integrity that the tobacco industry doesn't have. It puts together partners who are able to discuss ideas of what research should be done, as we're talking about today, to ensure that the most important problems are looked at not just in a scientific way that will look good in a peer-reviewed journal, but will actually help us make concrete, rational decisions and think through how those decisions will be most effective as we move forward, not only in implementing the policy, but advocating for the policy. It serves another purpose that we haven't specifically spoken about, and that is one of the tasks in tobacco control is always, how do we keep our issue in the public eye, framed as an urgent public problem that not only has to be solved, but to demonstrate to people we know how to solve it. This research provides an incredibly important tool for doing precisely that in an honest, objective, scientifically strong way. One of the reasons the partnerships are so important is because it allows researchers to do objective research and then others to take their research so that it doesn't just appear in a journal only read by PhDs who have no connection to what really happens in the world, but to put it on the front page, so that the public realizes both why it's necessary and what to do, so that policymakers understand why it's necessary and what to do, and to enable those of us who work as advocates to ensure that that information gets to the people who are making those decisions in real time. This project has done this better than any I've ever seen before. And lastly, if you want to measure a criteria for the effectiveness of this project, all you have to do, and we do this relatively frequently, is look at the frequency with which policymakers, both legislators and regulatory policymakers, cite this work as the reason for acting and for reason to making the choices that they have made. So if you want the perfect combination of bringing together good science behind a laudable goal to make sure you're doing the right thing and influencing the right people, this project hits it right on. So I don't want to repeat what's been said, but the examples you've heard are good examples. Let me show you a little bit about how an organization like ours and the many partners we work with use them, so that I've chosen 3 of the areas they've already talked about. Research on tax that you heard about earlier. The research on emerging products like e-cigarettes that you've also heard. In an area that often goes unthought about, but that Lisa's work has been so critical of bringing to the fore, and that is what goes on at the retail outlet. What is its impact, and what should we be doing about it? And the critical issues as we move forward in doing this. And why is this so important from my point of view? And that is the tobacco industry understood decades before we did that while tobacco is a public health problem, its solution is by and large a public policy problem. That the best way to reduce tobacco use is not one-on-one clinical intervention, as important as that may be, but by policies and programs that affect large numbers of people across a broad range at a cost-effective way and not only change behavior, but change social norms. The key to all of that is sound science if we're going to be doing that. Frank already gave you the data to show the effect of raising a tobacco tax. This is probably a cross or chart that has been shown in more places at more times in different ways in more countries by more people than you can imagine. And you know what? It is one of the single most effective scientifically based advocacy tools ever used anywhere. Nobody can misunderstand what it says. No matter how many lies the tobacco industry tells, you can figure it out. Even a member of Congress can figure it out in that respect. And the fact that it blows all the way is so absolutely critical. So, but let's give some examples, though. How do you bring this science to bear during a real live example here with regard to those issues? You know, 2015, Kansas was debating raising a tobacco tax. Kansas is not a place that's often receptive to these kinds of discussions, but they had a crisis in budget needs going forward. And yet the tobacco industry came in, and despite the decades of science, told Kansas that if they raised the tobacco tax, it would be not a reliable source of revenue. That maybe you would get a short-term spike, but it would drop like a rock, and every program that you intended to fund through it would end up shortchanged in the end. The availability of this project in Frank to come in very quickly and use solid scientific evidence to do a projection for the Kansas legislature of exactly what you could project to receive in revenue, not just in the first 6 months or the first year, but looking out long term because of the research base that had been done here. And so that we had models that were reliably tested, verified by experience to demonstrate what happens not just in the first 6 months, but year 1, 2, 3, and 4 and out as a result of it. And candidly, the expertise of the researchers here to come into the state, not to advocate one way or the other, but to present the data so that they were making decisions based on sound science, so that they could present the sound science to the news media covering the public debate, so that the industry's distortions didn't become the story as you came there, to meet with legislators who were struggling with wanting to be sure of what it was. It was a critical component to the success of that campaign. Another example, 2013, Minnesota raised its tobacco tax. The tobacco industry produced a classic tobacco industry study that claimed that along the border of the surrounding states with lower taxes, that there was massive loss of employment as a direct result of Minnesota's tax. There aren't even that many people there, but that's a separate question. But, you know, that is what we face in this issue on a daily and regular basis. The key here for us is the availability of experts, research models, to be able to produce a documented objective study based upon government data to demonstrate that, in fact, the increase of the tobacco tax not only didn't hurt employment in all of these locations, its positive effect throughout the state was extraordinary. And that not only did you not have to not look at the thing, but every single aspect of that tax had done exactly what the advocates had said it would do. It reduced tobacco use. It increased government revenues. It had no impact whatsoever on employment within the state. So, critical area. E-cigarettes are probably one of the best examples of the benefits of how this research project was structured. Because as you've heard, 2011, e-cigarettes were just coming onto the market. Suddenly, everybody is making claims of all kinds whatsoever. We have no solid base and no solid mechanism for beginning to make rational, thoughtful, evidence-based decisions. The availability of this project and the speed with which they were able to gear up research meant that very rapidly we were able to get the sort of basics that you wouldn't think you need to know. How many different variations of e-cigarettes were out there? How many of them had flavors? Who was using them? The kind of very core information that you have to have if you're not simply going to debate ideology, but you're going to debate facts. You're going to make decisions on a rational manner. So, in this case, Xu Hongzhu did in fact come up with a very early study there. And that was then built upon by other studies around there, so that we could say very clearly exactly what was going on. Equally as important is you could get it into the media, so that the media discussion wasn't just a he said this and she said this, and that you could begin to make decisions. We got it into the hands of legislators at all levels of government so that they could see those, so that you could begin to make very solid decisions based on what was in the marketplace, who was using it, how many products were flavored, how many of the flavored products were kids using, how often were they using them, the kind of core facts that are essential if you're going to make rational decisions with regard to it. And particularly important because we actually had a government agency that was making major decisions. Should have been made faster, but we're making major decisions with regard to that. So, here's a letter signed by 31 public health organizations commenting to the Food and Drug Administration about what it should be doing with regard to e-cigarettes, with regard to that. So, point of sale. I just want to call out Lisa in the work for this, because this goes under the radar screen so very, very often. And we have learned as a direct result of the research done here exactly how it contributes to the problem, exactly how it's part of an industry marketing campaign to reach low-income individuals, promote very specific core sets of products, get those products into the hands of the people who are most vulnerable at the lowest possible price, and things that you don't see if you just look at the price or so look at some big picture things. It allowed us all to target very concretely and very specifically what we should be doing about the retail outlet. Here's a perfect example where Kurt's research was used by the New York City Council as it was debating about whether or not it should ban price discounts of all kinds in there. And it was absolutely critical to the legislative debate. From a different point of view, it was critical in a very different way. It meant that the legislators were actually talking from facts that they could count on, that they could be sure that when they were making decisions, those decisions would have an effect, and the effect that they were seeking to have, at a time when the bodega owners in New York City were coming in and telling a completely different story with facts that had no basis whatsoever, trying to override and talking again about how this was going to destroy every store in New York City, that they were all going to close down, that it was going to disproportionately negatively impact the poorest of populations, as opposed to the data here that showed, in fact, it was their marketing that was disproportionately impacting the poorest populations. And no law-abiding retailer was going to get hurt one drop as a result of this issue. So when you come down to it as an advocate, this project is absolutely essential. It allows us to make smart decisions. It allows us to use our resources to ensure that the things we're working on will have the greatest effect. And it brings together the combination of researchers, advocates, and government officials to share information so that we can be sure that the research dollar is spent as wisely as possible, that the research when produced is used as widely as possible, and that it not only changes public policy, but social norms. Thank you.
Thank you, Corinne and April, Tracy, and Matt. I'd We're going to shift gears now, and I'd like to invite all 8 of the presenters to the dais, to the table up front here, and along with the presenters, I'd like to invite Dr. Matthew Farley, Chief Scientist and Senior Director of the Center for Health Policy Science and Tobacco Research at RTI, who's representing the Coordinating Center and the SCTC Steering Committee. So as people are settling in, I'd like to introduce Dr. Howard Koh, and with great pleasure, I might add. Dr. Koh is the Harvey V. Feinberg Professor of the Practice of Public Health Leadership at the Harvard T.H. Chan School of Public Health and the Harvard Kennedy School. Dr. Koh was, from 2009 to 2014, the 14th Assistant Secretary of Health for the U.S. Department of Health and Human Services. And prior to his federal service, Dr. Koh served for 7 years as Commissioner of Public Health for the Commonwealth of Massachusetts. Dr. Koh's leadership in public health policy and practice, as well as his internationally recognized scholarship, makes it clear why we're thrilled to have him join us here today and offer his thoughts on state community tobacco control research, and then moderate the panel discussion with folks here at the top. So, Dr. Koh, please. Thank you.
Todd, thank you so much, and welcome everybody. What a stunning afternoon. It's been really astonishing to hear this level of commitment to science and research and practice and passion and advocacy and a desire to make a difference here on the most important issue that our globe faces with respect to public health. I'm thinking about the famous saying that gets a lot of play here in DC, that the last time there was this much passion and intelligence in one room was when Thomas Jefferson dined alone. I mean, wow, this is really amazing. So I want to start by thanking the organizers of a really fantastic afternoon. RTI, Matthew Farley, Todd Rogers, and Carol Schmidt. The NCI, Liz Genexi and Michelle Block. The wonderful investigators that you've heard from, they've done a tremendous job here. The practice leaders that are so committed to making this all part of the standard culture for the future, and we're going to be talking about that. And then the steering committee, Frank Chalupka and Patricia Nez Henderson. If you want to put everything you heard today in the broadest context, what are we trying to do here? Well, if you take a big step back in history, over a century ago, the tobacco industry started a very successful movement to change the culture and establish a new culture that made tobacco use perfectly normal, glamorized that use, normalized that use, and the results have been absolutely devastating. So since then, so many, including the presenters here, the colleagues in the room, and so many online and around the world, have tried to change the culture back toward a tobacco-free norm. We've made a lot of progress, but we have a long way to go, and making change ain't easy. But we have to keep committing to making change. There's a wonderful saying that if you always do what you've always done, you'll always get what you always got. We made progress, but we have to keep being innovative, thinking of new ways to tackle these tremendous challenges and create and restore this culture that is tobacco-free and one that prizes health. Lately, in my new work back at Harvard, I'm thinking a lot about the word culture. It's interesting how you define the word culture. One of my Harvard colleagues told me a great definition of culture, which is the way we do things around here. Can we, with the passion and commitment, innovation of everybody here and many more, restore a culture that is tobacco-free and prizes health? These are some of the issues I've thought about in my career as a clinician, as a professor, as an advocate, as a government official. I know that one way to do it, as exemplified beautifully today, is to join better the worlds of research and practice. The world of research is very slow. I've been in that world for many years, and I'm back in that world. They call it research because you search over and over and over again. But it doesn't make any difference unless you put it into practice. And we have to practice until we make it perfect. One of the many things that SCTC has done beautifully, and Liz was telling me about this before we started, was that you joined the research and practice leaders together up front. Usually the model is you do the research in isolation, and then you come to some conclusion, and then you look somewhere for partners for dissemination, and that spends more time and years. And meanwhile, people are suffering preventable suffering. What SCTC has done is to join those worlds together. So that has been great. I want to hear more about that theme in just a couple minutes. And then we are in a time that is absolutely historic with respect to tremendous change. I had the great honor of being here from 2009 to 2014, as Todd mentioned. On my very first day of work, many of you have heard the story, the Family Smoking Prevention Tobacco Control Act became law, June 22nd, 2009. I will never forget that. And I don't know how many of you are spiritual. I am, because I raised my right hand on June 22nd. I got sworn in as the Assistant Secretary for Health. When I asked what my first duty was, they said, please go to the Rose Garden and support the President because he's giving FDA a unique, unprecedented authority to regulate tobacco. And I said to myself, this cannot be an accident. We got to see the Affordable Care Act become law in 2010. I'm going to be asking some of the colleagues, especially Matthew, about how we put this in the context of health reform. I had the great honor of working closely with a number of colleagues in the audience, Simon McNabb, Katie McMahon, Rosie Henson, to support Secretary Sebelius as we rolled out the first ever Health and Human Services Tobacco Strategic Plan in 2010. In 2014, I had the great honor of joining many of you and the Acting Surgeon General at the time, Boris Lushniak, to celebrate the 50th anniversary of the Surgeon General's report, where we celebrated some 8 million lives saved because of tobacco control, but very concerned that another 5.6 million kids were destined to die unless we changed and did something different. So here we are with some innovative strategies being proposed at a very critical time. But as many speakers have captured beautifully, this context is very dynamic and changing too with respect to novel products, the new emergence of e-cigarettes, the social media context, which is changing so rapidly, the intersection of tobacco, vaping, and marijuana. And so in response to that, we've had some very innovative proposals here that try to do new creative things, more emphasis on place-based initiatives, new partnerships like the 2-on-1 partnership, which I had not heard about before, so congratulations, that's fascinating. We're trying to make comprehensive changes with respect to Tobacco 21, with respect to public housing, with respect to tax and non-tax price strategies, lots and lots of creative issues to explore. So what I'd like to do now is lead the panel in some conversation and discussion about where we go from here. I'm going to take the prerogative of the moderator to ask the first couple questions, then open it up to all of you, and we go to about 3:40, 3:45. So the first question is, here we are facing the biggest public health challenge of our time. Nothing else is going to potentially cause 1 billion deaths worldwide in this century. We have so much tremendous activity going on, but in terms of the media and the public, this issue of tobacco control has dropped in terms of a sense of urgency and outrage with respect to the public. Many would say that it's actually fallen off the radar screen. And how do we get this critical issue back up on everybody's priority lists so we can take some of the progress that we've shown here and really accelerate it to save some lives? So maybe I can ask Matt Myers and Tracy Strader, and then maybe a couple of the panelists to weigh in on that. So Matt, you want to start on that?
Sure. It's the burning question. You know, in some respects, we suffer from our own success. You know, I think you can tick off a couple of reasons why we see so little. To the public at large, when we show statistics like we showed today, people think like we've won the war. Second, the one thing that has happened is that who smokes has so changed that no decision maker actually is ever around somebody who smokes. If I looked around the room today, not just in this audience, but today it's the poor, uneducated person who smokes, and so smoking has become a matter of poverty, and that shrinks it below. Third, while many of us remember vividly 7 CEOs of tobacco companies standing up and swearing under oath before a congressional committee that smoking neither caused disease nor was addictive, that's 22 years ago. There is not a single reporter covering tobacco in any major journal who was an adult at that point in time, let alone covered the issue. So when you talk about our anger and understanding of the duplicity of the tobacco industry, which is part of the story, that isn't part of the story for many of them, and it won't be as we move forward as we do there, which creates the lesson for all of us, I think, Howard, for me, which is it's our responsibility to tell that story in a live, vivid way today. You know, one of the speakers earlier referenced it. Today, it's the tobacco industry preying on the most vulnerable, the poorest of Americans. It is the tobacco industry that is crushing our healthcare system with costs from people who can't afford it. It is the tobacco industry that is driving a big piece of the growing disparity in life expectancy among citizens around there. And we will never get our arms around health disparities or health care costs, nor will we conquer cancer if we don't conquer tobacco. But we have to be innovative every single day to make sure that the media hears those pieces of the story. And if we don't do that, then it won't appear on the front page.
All right, thank you for your leadership on that. Tracy, did you want to comment too?
Just primarily to echo what Matt just said, as far as, you know, the tobacco industry behavior, I think they're getting off scot-free these days. As I said, most people that I speak to don't even remember the settlement, much less the swearing. And, you know, with the settlement came all of that exposure about why we had the settlement. And I think one of the opportunities we have looking forward are these corrective statements that'll be coming out. I also think that if they'll be coming out, I also think that we really have to use these data, this science, uncovering what's going on with e-cigarettes, what's going on with this retail marketing, being able to show the scientific truth of these things can help expose the industry's behavior and get people a little more impassioned about doing something about it. And I agree, it's very difficult when you say nationally we've reduced smoking from 50% down to a quarter of what it was. Certainly not the case in our state, but I think we've just got to make this issue real. And without that memory of the industry's behavior, then people are able to fall back on it's a legal product and a legitimate business. I actually think it was Matt Myers who told one of my board members years ago that it's not just a legal business, this is unethical behavior. And we need ethical businesses to stand up and say, this isn't the way we do things. And I think people have forgotten that, but we can provide this kind of science, this kind of data, and help impassion people.
Thank you, Tracy. Other panelists want to weigh in on this one as we start in? Frank?
So I'm an economist, so I'll put in a plug for pushing for some economic arguments around this. I think one of the things that we don't really have a good handle on is just how much tobacco costs society economically. We have some basic measures of things like healthcare costs and some estimates of lost productivity, but we really don't have a comprehensive sense of how much it costs. And we need to do a better job of making the economic case for why investing in tobacco control is a good thing to do. I come from a state where our budget is a disaster at this point. We don't have one. We haven't had one for 9 or 10 months at this point. But you know, the state is hemorrhaging money at this point, and raising the tax would get them some revenue in the short run, but it would also save a lot more in the long run. And we need to do a better job of demonstrating that. So building the economic case as well.
Okay, great. Thank you. Let's keep going on with the economic issues. And so many people in this room have been at this for so long, and you've seen ups and downs in tobacco control budgets, mostly downs. Sometimes I think of songwriter James Taylor. We've all seen fire and we've seen rain, right? So for those of you who are in the trenches, you know, April and Tracy and others, how do you deal with the current situation with tough budgets, and how do you leverage what you have to make the biggest impact?
Well, I think that we have a lot of good partners at the local level and then with the research community. California really benefits from the partners at the Tobacco-Related Disease Research Program and through the SCTC. We've just expanded the reach of our program because we've got all of these researchers doing work out there. And we're also working with other partners in public health around nutrition, alcohol prevention, and now sexually transmitted diseases, which is not a partner that I would have thought of. So I think our whole concept is when you engage more people, you have more people spreading that message. And that's one of the tools that we're using.
Okay.
And I'd say the same thing for Oklahoma and states like ours. We too have a huge budget deficit this year, and that's the reason the cigarette tax was, the dialogue began. I think the economic arguments are strong, the public health arguments are strong, the industry is strong. So, you know, we have to get scrappy. I think sharing and leveraging resources is just critical in partnerships. And I have a friend who always says R&D doesn't really stand for research and development, it's rip off and duplicate in a good way. And so I think that's one of the things that the SCTC research and allows us to do, as April mentioned before, taking those toolkits and fact sheets and bringing in testimony, not having to recreate those things, so that we're using our dollars as efficiently and effectively as we can, and using that science to help guide where to put those dollars.
Great. Other panelists want to weigh in on this one? Okay, let's keep going. You've heard a great afternoon of how the worlds of research and practice can work even more closely together than before and sort of do a lot of planning up front. So where do we go from here with respect to making these worlds work more closely together? Again, the research world is slow and the policy world is fast. So what are some lessons learned now from your past 5 years about how to make that accelerate even more in the future, and how do we spread the word in the R&D style that Tracy was fondly talking about? Who wants to comment on that?
Well, I'd like to just
Okay,
comment. I
April?
think one thing that NCI and SCTC did really well is that they put together these work groups that met on a regular basis that engage practitioners and researchers together. And it's over time that you develop relationships, and then those relationships actually build. So with Michelle on the Smoke Free Home Project, you know, we're implementing that in California, but I knew that she was also working on that to adapt it to the American Indian community. And, you know, we're looking to provide funding to help facilitate that. But it's just through the relationship building. But SCTC provided the forum for those relationships to grow. So I think that that was really important.
Michelle, you want to add to that?
Well, I just want to jump in real quick and just say I think the rapid response funding has been critical, and that really does help with bridging practice back to research as well.
Go ahead.
Yeah, I agree with that. So it is the relationships and the flexible funding as part of this initiative. So just an example of that is our current developmental project is working with the state of North Carolina's tobacco control program. And they came up with the idea, actually, the research question, which is to look at the decision-making process for affordable housing versus public housing to implement smoke-free policies. And of course, smoke-free multi-unit housing is a big issue in tobacco control right now. So we were excited. We proposed that, got blessing of the group to go forward with that. And then all of a sudden, HUD had this remarkable movement in potentially, it's under discussion now, I understand, to have public housing go smoke-free. So that would affect the decision-making process, of course, because they would just need to do it. And so that kind of changed our research question, but in a good way. With the flexible funding, we're able to refocus a little bit and document how the early adopters in the public housing authority world were able to implement this policy. And so we plan on coming up with some useful tools for the public health community. It was the relationships we had with the tobacco control folks at North Carolina, and then it was the flexible funding. So that combination's been remarkable in this initiative.
Okay. So go ahead.
I would add to that STARS wouldn't exist were there not collaborative developmental funds available through this initiative. It would be a 2-page form and a 90-slide set deck on a website that no one would know about. With collaborative developmental funding, we were allowed to create a user registry, survey people who downloaded the form, complete case studies in 4 states that were early adopters to understand what worked and didn't. And the idea that so many states are now using this is a testament to flexible funding and the opportunity to work hand in hand with partners in a quick way.
Go ahead, Pam.
I just wanted to add my enthusiasm for this pilot funding, which is, just extra money we got every year to use for an innovative project. In our sense, we get almost all of our pilot projects were done by postdocs or junior investigators who were responding to something they saw in the field. It was allowing us to be able to do some of the first research on things like electronic cigarettes. The triangulum between tobacco, e-cigarettes, and marijuana was proposed by 2 postdocs in 2014 as an interesting area. Now it's all over the place. And and even to look at things like buying loose cigarettes in New York City, where apparently you can buy a cigarette for $1 when you pick up your dry cleaning or your Chinese food, was something that we were able to respond to and detect very quickly, and also to engage a whole younger generation of scientists in a way that was very flexible.
Great. Thanks for all that. Go ahead, Matt.
Research, I think this project has shown that research doesn't have to be slow, and it doesn't even have to be reactive. If it's done well. And I think that's the important lessons. I mean, as we've all listened today, we've heard pretty clear from Pam the importance of research as the industry innovates products, to get out in front of that so that we can make strong, thoughtful decisions. We've heard separately both the changes in retail outlet and changes in sales and marketing online, the importance of investigating new ways that the industry markets, the new sets of themes, the new way they target audiences that aren't as visible as the old newspaper ads, that both one needs to identify and then figure out how you address. And then third, we've heard very clearly that today's smoker is different. And that means we need to document a host of really critical items with regard to that, not only who that smoker is, but how we most effectively reach that smoker. And that's not long-term research. I think you could do that quickly. We need to document what that smoker is costing society to address the issues that Frank talks about, because it's very different when you're talking about smokers who are upper middle class, college educated, who come down with various tobacco-related diseases, as opposed to a Medicaid population who are having many children, costing society enormous amounts of money, and it's just going under the radar screen. Research needs to help us identify those, pinpoint solutions to them, and demonstrate the cost effectiveness of dealing with them and the cost of not dealing with them.
Wonderful comments from all of you. So let me ask my last question before we open it up to the audience. So we are doing all this work in the era of health reform. The Affordable Care Act just passed another anniversary, and the 6th anniversary in March, and lots of buzz in the media about marketplaces and about Medicaid expansion, which states are doing it, which states are not. Very important to keep reemphasizing that in this conversation are some very fundamental public health and prevention themes that are being raised. So Matthew, can you just comment more on maybe that, and maybe Corinne too?
Sure. I mean, I think that, we all know that when a doctor talks to a patient that smokes, that they're more likely to quit. And there's a lot of effective support for smoking cessation, nicotine replacement therapy, pharmaceuticals. But of course, both of those things have to happen, that there has to be that conversation, and people have to be aware that those supports are available. With the Affordable Care Act, and especially the Medicaid expansion, there's a lot more support for low-income smokers to quit, and quit with support. But there are a lot of gaps in that implementation, One, not all states have, of course, the Medicaid expansion, and therefore it limits the amount of Medicaid support for smoking cessation. And even if it is there, we still need to build the infrastructure, with a lot of sort of day-to-day work with health systems change, so that the doctors are prompted to have those conversations with smokers and support their smoking cessation efforts. But also, frankly, many of the Medicaid recipients that smoke aren't really fully aware of all of the new benefits that are available. So I think that there's a historic opportunity to build the infrastructure, to create the awareness and fully take advantage of all the opportunities that the Affordable Care Act and the resulting policy change has given us. But there's a lot that we still don't know, and how to get that to happen, to get it fully implemented and understand its impact. But our colleagues here presented earlier on the great disparities, how smoking is still quite high among low-income smokers. So there's that great need and there's a great opportunity, but we just have to put those two things together. I think one thing that maybe was implicit in earlier comments, but as another economist, I think is important to point out, those interventions that I'm alluding to are some of the most cost-effective interventions that exist in public health and in healthcare. And also, Frank and I, over time, have shown that investments in state tobacco control programs have led to reduced youth smoking, reduced adult smoking, and has shown a return on investment that's quite significant. And I think it's one of probably the most impressive public health interventions that exists because of all the evidence base that's behind it. So I think that it's a shame that the coverage of all these issues has dropped, because I think that it's still such an impressive body of work and a huge public health impact.
Great comments on the return on investment. ROI theme is something that the budget leaders always want to hear about, especially in towns like this. So thank you for raising those. And Corinne, go ahead.
I was just going to, I think what Matthew said is exactly part of what we're focused on, which is really how do we understand access, how do we understand and address barriers to the cessation support in the system, so not just for the individuals, but what are the barriers within the systems, and then also the promotion piece, which you've already mentioned. So the other thing that I think is important for this group to understand is that from the standpoint of the transforming health system, they are moving from paying for fee for service, so paying for individual services, to paying for outcomes, paying for the actual health-related outcomes. So what we're seeing, and I think what all of us need to figure out how we start to take better advantage of, is that there are systems that are actually moving toward the population health kinds of interventions and working to figure out what does it look like to have their system working in smoke-free, clean indoor air, for instance, that space. How do we get this, how do we cultivate these individuals that are now responsible for and becoming more and more responsible for a population impact, in some cases beyond their patient population to actually the geographic population that they're serving within their system? How do we take advantage of that, and how do we start to use them to bring some of the visibility that Matt's been talking about, to also help support some of the policy interventions that we're working on that, again, go well beyond just the access to the cessation support for the individual smoker?
I'm so glad you mentioned that, Corinne. And if all of you are following what the Innovation Center at CMS, the CMMI, everything's an acronym in this town, is doing, they're really trying to promote the concepts of population health. There's an initiative they announced just a couple of months ago about accountable health communities, where they're trying to tackle so-called social determinants of health. When I heard the presentation about partnering with 211, and those are the folks who need services in all parts of their lives, not just with respect to this one issue. And can there be some partnerships built there that CMMI could fund and test and evaluate with all your support? That certainly crossed my mind as one who's been following all this. Okay, so great conversation so far. Let's open up to the audience. We've got another 15 minutes or so for questions from the audience, comments, thoughts. If not, I might call on you. Professor Koo? Do we have a microphone right here?
I must admit, I've come to the tobacco control area fairly late in my career. I've spent most of my life dealing with sort of health policy and Medicaid issues. But one of the things that it keeps being an issue that I've noticed, and I deal a lot with Medicaid, is the fact that Medicaid and public health agencies don't talk much to one another, and this issue has not been raised. There are concerns about a lack of resources. Healthcare expenses are continuing to grow. There's no question that more money by far is spent on Medicaid or private health insurance than all public health efforts by several hundredfold. We did some estimates that basically said the amount spent on tobacco control and Medicaid is maybe 0.25% of what we think smoking costs in Medicaid. So the question that I have is how can we pursue a little better dialogue to try to sort of make health systems think not only about cessation, but prevention. And if this can be something that we're not only trying to think of public health as a completely separate entity, but how can it also sort of penetrate with that other area of health? I think there is some potentially huge promise there.
Great point. And for those who haven't followed this, people on Medicaid have smoking rates about double that of the general population, so they're very high risk. Professor Koo has done some work showing that a very low percentage of smokers covered by Medicaid are actually taking up cessation services as offered by the Affordable Care Act. So that's an area that needs a lot of progress. I don't know if any of the panelists want to respond to this.
Can I
Matt,
make
go
a
ahead.
comment?
Yeah.
Too often in the past we've all thought about cessation as the one-on-one clinical work, as opposed to there's a public policy component to cessation that has received far too little attention with regard to that. We have the experiment in your state, Massachusetts. Yep. Where people got together and got the public health agencies and the Medicaid agencies talking to each other and came up with a program that dramatically reduced tobacco use among Medicaid recipients. Right. Within 3 years, produced $3 for every dollar spent. And one of the questions we have to ask ourselves is why haven't we done that in every single state in the country? That makes no sense. Why hasn't the Innovation Center been at the forefront of that? Why hasn't this administration candidly used the Affordable Care Act as a tool to get that message out and provide incentives across the board? The second component to that for advocates and state officials, you don't need to be in a Medicaid expansion state in order to expand cessation services to the Medicaid population. So that for all those states that haven't done it, that's not an excuse for us not going in and advocating that they do it. So cessation ought to be thought as a public health tool, not just a one-on-one clinical tool, and we ought to be talking about the same kind of strategic thinking about how we ensure that cessation is promoted among the Medicaid population effectively in every state, and that how we use that boost as a prevention boost to create healthy families, healthy children among the most vulnerable of our populations. We've got models for doing it. We simply haven't devoted the same kind of attention to that we've done to some of our other policies.
Great comments. And the Massachusetts experience that Matt is commenting on about my state, Massachusetts, if I can say, I'm very proud to say, demonstrated a very strong ROI for those efforts, return on investment. So we've tried to get that word out, and we need more work in that area. Did others want to comment on this theme about Medicaid and tobacco? Yeah, please, go ahead. Maybe April, go ahead.
Well, I would say in California we actually have a good relationship with our Medi-Cal program, but that could be because the medical director actually worked in the Department of Public Health and he crossed the street. And we have work groups around cessation and around behavioral health. And Shuhong Zoo was actually funded by CMS to do a really large program with promoting cessation to the Medicaid population. And it's like, if you incentivize people to call the quit line, they'll call the quit line. If you do direct mailing to let them know about the benefits that are available through Medi-Cal and through the helpline, they'll call. So, it takes some resources to do that, but I think that was a wonderful partnership between public health and the Medi-Cal program in California.
Has that been written up, published,
No.
or advertised, or in any way?
We're waiting for Shuhong on that.
Yeah, let's get that up and out, because the Massachusetts one we've talked about because it's been in press for a while. But that's another way where research can really affect practice in a very dramatic way. Any other comments on this very important question? Thank you so much for raising that.
Quickly, if
Yep.
I could, I think Oklahoma also has a wonderful relationship, and I think it's important to realize that it's about relationships. As long as you look at it as an entity and an organization, you're not going to bridge that gap. And, I think one of the things our state health department has done a fabulous job of is really moving in relationship to the Medicaid agency away from just transactional kinds of discussions and into quality discussions. And what can we do to improve quality here? Everybody's interested in that. So we've given a grant to our Medicaid agency. We leverage their dollars and get a federal match on many of our programmatic work. And I think it's just different state to state, and probably worth giving a call to some of the folks who've bridged that gap pretty well.
Lots of cultures changing in lots of places. Okay. Dr. Abrams has the next question. Okay, go ahead. All right.
Pass it over.
And then Dave will be next. Please go ahead.
Alicia Smith from ASTHO, and my question is really about if any of the research that you did demonstrated or showed how to communicate to those populations that were referenced that are so difficult to reach, how to communicate to them to access the actual services. We talked a little bit about ACA earlier, and I think when we talk about ACA and Medicaid expansion, we're likely talking about populations that didn't have access to the healthcare system previously. So I'm wondering if any of the work that you did showed or demonstrated some ways to get those populations to actually access and navigate the services. My staff and I work on chronic disease prevention with states across the U.S., and oftentimes the question that we get is that it's difficult for us to promote these services because they don't understand how to access them. And it's very difficult to talk about chronic disease without talking about tobacco prevention. So likely if they're not coming in to get screened for breast cancer, they're also not talking to anybody about tobacco cessation.
People want to react to that one? Go ahead, Michelle.
I can start. I think this is where innovative partnerships come up. So the 211, which has gotten a lot of attention today, which is great. Low-income folks call them for reasons that have nothing to do with health, unless you take a social determinants frame, of course, just for basic needs. And so I think they're a really nice partner for tobacco control, and I believe another grant was just awarded to begin to make these connections even stronger. So I would look for channels and partners that reach low-income populations naturally and then partner with them. And then just, we used incentives. We always incentivize our research participants, but now in California, with our dissemination, we're realizing, we do need to incentivize people. If you incentivize them, they will take advantage of these services. So we're starting to view our program as also including incentives to participants to get them interested in it.
Matthew's going to say it's all about economics, right?
Yeah, maybe.
Or Frank?
No, I wasn't. I was actually going to give a similar example.
Okay.
I work with the folks in New York Health Department, and they've been trying to figure out ways to create systems change to get the benefits to the people who need them. And so they've been focusing on federally qualified health systems and making sure that when someone comes in the door that they are prompted, if they're a smoker, to have that conversation. So that's another one of those innovative ways of attacking the problem.
Yep,
I think there's another important point too, which is as much as we still need to learn, the recent studies have reaffirmed that we actually do know how to reach low-income populations. The disparity in tobacco use among low-income populations based upon where people live, as reflected in the recent Chetty study, which contributes so heavily to the disproportionate impact on life expectancy, demonstrates that in cities and states that have engaged in comprehensive tobacco control programs, that they have effectively, not as effectively as we like, but they have made a very dramatic change in tobacco use rates among low-income populations. So that I think it's a mistake to say that we don't know. We have much more to learn. But the recent data shows that in states that have actually tried, that have adopted these kinds of programs, that have adopted community-based programs, mass media programs, that have raised their taxes, that have aggressively provided smoke-free air protection, that it has had a dramatic effect on smoking rates among low-income populations, and that it's people who live in states that have done none of those things that are most at risk. So I think it's unfair to say either we don't know or that those people won't change their behavior. I think much more responsibility falls on we haven't tried hard enough in a lot of places.
Okay, Pam, did you want to comment?
I would just add that we have actually learned a lot about how to identify and speak to high risk, in our case, high risk young people, and to communicate with them in a culturally specific way, as well as recognize that there is a conversation about tobacco going on in places like Twitter and YouTube. It's just not about how to access services, but to be able to think innovatively about how to get in and become part of that conversation and to do those strategic partnerships, I think, is another place we shouldn't forget.
Thank you. Let's move on to Dave's question.
Yes, so I think you started this with saying we've still got 1 billion people worldwide that are going to die. The Surgeon General's report pretty much, I think, had a radical statement in the executive summary, which said the overwhelming number of deaths due to tobacco is due to combusted cigarettes, inhaled smoke. And could there be a set of policies that would much more rapidly reduce the death and disease by adopting essentially a program of harm reduction where you allow for safer regulated forms of nicotine other than medication for those that cannot or will not quit? And given that deeming is imminent, I think, although we don't know for sure exactly when, we have an enormous opportunity to look at rethinking nicotine in light of alternative delivery systems that could be reasonably safe if properly regulated, could be a tool, and I'm particularly concerned about those with vulnerabilities like mental illness and so on, because there's a wonderful article in Molecular Psychiatry showing that there is a sort of hardening of those that are using tobacco and cannot quit, and it's predominantly those with mental illness, substance abuse, comorbidities, and things like cognitive problems like inattention, ADHD, where nicotine is an incredibly beneficial medication, and you therefore wouldn't say to a biologically depressed person, you're addicted to Prozac, and I want you to get off all of it eventually. So my question to Frank and others is there a new role here for a harm reduction approach that rethinks nicotine as what I've called a friend, frenemy, and enemy? It's an enemy to kids, and we all agree, just like alcohol, which we couldn't prohibit. It didn't work. We got to keep all of it out of the hands of kids completely as best we can, just like alcohol. But there will be an unintended risk of some kids doing it no matter how well we do that. But is that such a fear that we would be blind to what the Royal College of Physicians in the UK has done? And by the way, they're an august body that started in 1962 and issued their first report 2 years before our Surgeon General's report. And last week they came up with an absolutely comprehensive, highly strongly science-informed position that's quite opposite to the US position. What's going on here? Is this ideology blinding science and evidence, or something else? So what can we do to look at harm reduction as a tool to accelerate the death and disease without prohibiting nicotine, but rapidly getting rid of combusted tobacco as the ultimate evil? So the end game is combustion, not nicotine elimination.
We're ending with a nice, easy one here. Who wants to comment on this issue? And as Dr. Abrams has pointed out, lots of discussion about this. some very fascinating views being expressed by our colleagues in the United Kingdom. Just a critically important issue for us right now. So I think he called on you, Frank, right?
Not me specifically, but so,
Lucky you.
yeah, lucky me. So I think I'll come back to my favorite policy, which is tax policy. I think there's a lot of room for using differential taxation to really start to push things in a direction that promotes harm reduction. So we know tax is very effective across the board. Some of the work we did for SCTC shows that the demand for every nicotine product responds to price. And what we're learning is that sort of the choice of products and which products people use and how they use them also depends on their relative prices. So I think that this is an area where we have a lot of room to use big tax increases on combustibles, coupled with perhaps smaller taxes on other less harmful products, to really try to push things in the right direction. So we know if you put a tax on e-cigarettes, that's going to discourage kids from using them. We've got some work in progress as part of this initiative that suggests that the elasticity there is enormous, I mean, relative to what we've seen. So it's kind of, we saw it with e-cigarettes versus cigarettes in some of the data that we've been looking at. We're seeing the same sort of relative effects for kids with e-cigarettes that we see for cigarettes, so 2 to 3 times more responsive. So, a big combustible tax increase is going to keep kids from using combustibles. Putting in a significant e-cigarette tax is going to keep kids from using e-cigarettes. And then having that differential is still going to allow an opportunity for the people who can't quit smoking to switch to something that's going to be less harmful. And I think, there's a big debate over whether or not people are using these products to quit, but I think some of the data that Pam put up, if I remember right, that suggests the type of product that people are using may differ for people who are trying to quit with these products versus people that are using them to maintain their addiction to cigarettes where they can't smoke cigarettes. So I think, again, structuring that e-cigarette tax in a way that treats the disposables, the Cigalikes, in a very different way than you treat the open systems that seem to be being more used to promote cessation, I think is a real sensible thing to do. So we'll start, as a researcher, it's going to be fascinating to watch how these taxes roll out over the next few years. We are seeing some governments, Chicago's tried a creative approach, I think, that's starting to move in that direction. So we will have some opportunities to explore this, but I think taxes is really a key place to start.
Are there comments on this fascinating question?
Well, I'd like to comment on
Go ahead, April.
Because the California Tobacco Control Program is actually getting emails from people in the UK telling us that we're being irresponsible with our e-cigarette media campaign. And, what we're doing in California, we've always done is a denormalization program, which is very different from the approach taken in the UK, which has focused really a lot on a cessation approach. So we're trying to change the world in which kids grow up in, and it's adults who control that world. So we are focused on things like smoke-free environments, tobacco taxes, smoking in the movies, those kinds of things. And, we're looking at the scientific literature, we're looking at the U.S. Preventive Services Task Force guidelines, we're taking guidance from the Tobacco Education Research Oversight Committee. And we feel very comfortable with the approach that we're taking towards e-cigarettes. And right now, those products exist in an unregulated environment. We don't know what the content of these is. We don't know what the long-term safety of these products is, the labeling of these products, the taxation. There's a lot of problems right now related to the sale and marketing of e-cigarettes. So this question of whether we should take a harm reduction approach, I think, is way premature. We actually don't have the evidence that says that's a good approach at this time.
Howard, can I just jump in with one thing, too, which is not to debate the merits one way or the other. We actually have a mechanism in this country for working this issue through, which is called the Food and Drug Administration. It has responded horrifically slowly in doing that. But it is provided with the authority to give us answers so that we could make decisions based on sound facts. I think over the long term, one of the things that's going to measure the actual success or failure of this act is the extent to which it finally steps in and whether or not it adopts a set of rules and regulations to rein in the very harmful behavior that's been out there, to give us answers as to whether or not any of these products are effective at helping people to quit, and then to draw the market to those products if they are, and to discourage the sale and marketing of those products that are not. With regard to that, the way to solve this isn't for a bunch of people to debate, contrasting science without an objective decision maker. The reason we have an agency like the FDA is to set up a set of rules to determine the kind of science that we need, to set up a process so that there's objective decision makers, and a set of rules to curtail the bad behavior and incentivize the good behavior. And in the absence of that, then I think everybody will continue justifiably to be very nervous.
Thanks, Matt. I'm going to have Matt, maybe, and then Frank make the final two comments, and then we're going to end this Q&A, but go ahead.
Yeah, it
Matthew?
probably takes the whole panel to answer Dave's question appropriately, and I'll just take one piece of that. And one big difference between the UK and the United States is the explosion of use of e-cigarettes and related products among adolescents. We've seen that use rise so very quickly recently, and now it exceeds the rate of cigarette smoking in the United States. And we've shown, I did a randomized experiment exposing kids to e-cigarette television advertisements, and did show that piqued their interest in using e-cigarettes in the future.
Right.
So that is one difference that we do have to keep in mind between the UK and the US is how do we keep it out of, as you pointed out, how do we keep it out of the hands of children who could start with maybe just e-cigarettes but then progress on to other products. And also, as April pointed out, even if they just stick with those products, we don't know what the long-term consequences of using e-cigarettes with all kinds of crazy flavors, the toasted marshmallow and other flavors that was pointed out earlier. So that's a very important consideration as we think through the whole problem.
Great. Frank, you have the last word, and then we're going to close.
I just want to bring it back to what this initiative is about, which is state and community tobacco control. I don't want to wait for FDA to figure out what they're going to do with e-cigarettes. States and communities have the ability to do a lot. And we're seeing it starting to happen with tobacco, with tax, but we're also seeing it happening with flavors. Chicago has an innovative ban on sale of every flavored tobacco product in stores near schools. So there's a lot of things that states and communities can do, and there's going to continue to be a need to figure out what's working and what's not working.
What a fantastic panel. Big round of applause for our panel here. Thank you. And Todd comes back for the final word.
Final word. Thank you. Thanks. So I have to say I'm very proud of being a part of this initiative. I think you all agree this has been a remarkable number of years, and thank NCI for their support and confidence in all of the work that everyone has done here, and the coordinating center as well. It makes me feel good that this event reflects the mission of RTI, which is to turn knowledge into practice. So thank you for supporting our mission too. You didn't know that. I want to thank the many RTI colleagues who kept this mission in mind and worked tirelessly to organize and facilitate this forum. I'm sure my SCTC colleagues would agree that a special shout out is deserved for our project manager, the multi-talented Wendy Elkins in the back. On behalf of the SCTC Steering Committee, I'd like to thank Dr. Coe, our panelists, all SCTC investigators for making this such a terrific event. We look forward to continue with you on the journey towards a world where everyone is free from the devastating consequences of tobacco use and exposure to tobacco smoke. Thank you. Have a great afternoon.